Good morning. We'll go ahead and get started. A few housekeeping items to remember. In-person attendees need to sign the sign-in sheet for today's session if you have not already done so. A reminder that all virtual participants are set to mute. If you have a question, please type it in the Q&A box and we will have the speaker address it at the end of the session if time permits. If not, we will collect answers from the speaker and distribute the response to all registrants. All presentations will be able to view on demand online for 1 month following the conference. Attestation forms needed to claim CME credit may be completed by attendees on Sunday at the close of the conference. These forms will be distributed to in-person attendees and are available online for virtual attendees. PDFs of today's presentations are available at LMU-Live.com, and disclosures for all speakers are available for
All right, good morning, everybody. Thank you for coming. I know it's early. Like Dr. Brown said, I am Dr. Hall, double board certified dermatologist. I'm practicing at Jenny Stewart Medical Center currently, and I graduated in 2016. I have no relevant disclosures for today's talk, and we're going to be talking about dermatology in the real world. We're going to be covering a lot of ground today in the next 50 minutes, so hopefully you find this fruitful for whatever specialty you're in. Today's objectives, I want you to be able to describe at least 2 steps in the appropriate workup of common skin lesions and things that you would encounter in the outpatient setting. Articulate 2 situations in which to refer a patient with a skin issue to a dermatologist, and then explain at least 1 element of morphology and a differential diagnosis for both benign and malignant lesions, and then demonstrate the ability to develop a treatment plan with key elements of pharmacology for commonly encountered skin conditions like acne. So let's talk about what we're going to cover today. We're going to go over morphology. A lot of times there's this misnomer of things being described as maculopapular. So I think having a good understanding of morphology will help set the framework for your differential diagnosis. We'll go over the ABCDEs of moles and how to evaluate for skin cancer, things that itch, and then common skin concerns that you may see in the primary care setting. So diagnosis of skin disease. When a patient comes to your office and they have, say, a skin lesion, really the most important thing is understanding a good history. You're going to want to ask them, when did this start? Where did it start? Their primary lesion, and that's where your morphology will come into play. And then that will help you go into your differential diagnosis and your management, so whether you need to do biopsies, scrapings, or blood work. So our first topic, which is the morphology, and these are lesions that you'll be able to describe as far as your primary lesion. So a macule is a circumscribed flat lesion that's less than 6 millimeters in size, so less than the size of a pencil eraser. They're not palpable lesions, and they often don't have that secondary characteristic of change. So there's no scaling. They can take on various color forms: brown, blue, red, hypopigmented. And examples of this would be macules, moles, lentiginous, which are sunspots, vitiligo, idiopathic guttate hypomelanosis, which is basically these white spots that you see on the skin in the picture here on the slide. A patch is a broader area of a macule, which is circumscribed, it's flat, and it's greater than the size of a pencil eraser. And here you can see in this African-American patient, there are these patches of vitiligo on the hands. Papule is elevated and circumscribed. It's less than 1 centimeter in diameter. Its elevation is really due to increased thickness of the epidermis, and it can have secondary changes, so scaling and crusting. Plaques are again elevated, they're circumscribed, and they're greater than 1 centimeter in diameter. So really the size kind of differentiates between these two. Nodules, they're elevated, they're circumscribed, they're generally greater than 2 centimeters in diameter, and they involve both the dermis and the subcutis. This would be your classic epidermoid inclusion cyst, lipomas, metastases, neurofibromas. Vesicles, they're less than 1 centimeter in diameter, and this is where it's important that they are filled with clear fluid. This would be your herpes simplex, varicella zoster, dyshydrotic eczema. Bulla, they're larger than 1 centimeter, and they're also with clear fluid. This would be bullous pemphigoid, coma blisters, friction blisters, and then pustules. They're very similar to vesicles. They're less than 1 centimeter in size, but they have purulent fluid. So this would be your folliculitis, your acne. Secondary changes worth mentioning would be crusting or scaling, which is accumulation of the stratum corneum due to increased proliferation or delayed desquamation of the skin. Fissures, erosions, ulcerations, excoriations, atrophy, lichenification, those things. But those don't actually define the lesion. They're just kind of descriptive characteristics. So now that we have an understanding of our morphology, it can help to navigate the differential diagnosis, especially as it pertains to the primary care setting. One of the more common things that may come to your office is a patient wanting to know if their mole or their skin lesion is fine. This may be something that's been on their skin for years and hasn't changed, or it may be something new that's rapidly evolving. So a good history of family as well as personal skin cancer history should be asked. They should be asked about sun exposure risk factors like sunburns, tanning beds, as well as the use of daily sunscreen, SPF 30 or higher. A classic example would be a patient who tells me, I never go out in the sun anymore, but when I was younger, I used baby oil and I used to fry in the sun. So most times the damage is done from years of prior sun exposure and not necessarily due to anything recent. So we'll talk about benign, normal appearing nevi versus lesions that would require further evaluation, like a shave biopsy or in-office treatment. As a general rule, if your patients are coming in and they want to know, what are some things that I can screen for at home with skin cancers, your ABCDE of moles is kind of the good general framework to have in your back pocket. So A would be asymmetry. If a lesion, if you will fold it in half, one side should look like the other. Moles should have smooth, round borders. If they have any sort of jagged border or a sharp edge to it, that should kind of trigger an alarm for you. Color distribution, moles should have a few shades of brown. They really shouldn't have red, white, or black in them. And then diameter, anything bigger than the size of a pencil eraser should be evaluated. Biggest thing is looking for changes in size, shape, or color. So let's talk about normal nevi. They appear in childhood, they increase in number and in adolescence, and then they peak around the 3rd decade. They're brown macules. They can be raised, but they're generally that 6 millimeter in size or less. They have a homogeneous surface, they're evenly pigmented, and they're sharply demarcated. If you look closely, you may see even perifollicular hypopigmentation. In office, I'm able to use something called a dermatoscope, which helps me see the architecture of the lesion a little more closely. But this, you can see this perifollicular hypopigmentation, you can even see with the naked eye. So there's 3 types of benign nevi. Your junctional nevi, which is your macular or your thin papule. It has preserved skin markings and it's brown or black. There may be even darker pigmentation in the center. They can look like simple lentigines or sunspots. Compound nevi, they're a little bit bigger, so they can be papillomatous. They're various colors. They can be either smooth or dome-shaped, and they're pigmented as well. And then your intradermal nevi, which you may see more commonly. These are a little thicker, they're tan, they have a rubbery texture, and they often have terminal hairs extending from them. Management, really you don't need to do a whole lot for these. You can just observe these over time. If a patient has numerous nevi, they should undergo periodic skin examinations and then be counseled on sun protection. The American Academy of Dermatology does not have a standard of when to start skin checks or how frequently. For adults, you can tell them monthly self-exams can be done at home, and then it's recommended to evaluate any lesions that are changing in shape, size, or color. And then routine skin checks are not recommended for children. General sun protective measures should be advised, so staying in the shade, particularly in peak sun hours, which are 10 a.m. to 4 p.m., SPF 30 or higher, reapplied every 2 hours when in the sun, and then UV protective clothing. So the biggest thing that you want to screen for with these lesions, that if a patient comes in wanting to know, is this spot fine, is a melanoma. So this is the most serious form of skin cancer, and there's 4 major subtypes. There's superficial spreading, nodular, lentigo-maligna, and acrolentiginous. So again, you're going to want to screen them. When did this lesion start changing? When did the lesion start? Is it itching or bleeding? Oftentimes skin cancers can bleed, and that's the only manifestation of them. Is there a personal or a family history of melanoma? And have they had blistering sunburns in their childhood or their teenage years? And are they immunosuppressed? Again, risk factors would be, lighter complected patients, red or blonde hair, light eye color, and then a large number of nevi, so greater than 50. Superficial spreading melanoma is the most common subtype. About 70% of melanomas are diagnosed in this stage, and they're confined to the epidermis, so they undergo this radial growth phase. More than half of these lesions are diagnosed at less than 1 millimeter in thickness, and they're highly curable by surgical excision alone. They have a predilection for the back in males and for lower legs in females. And again, you're going to look for those irregular borders, color variation of red, white, blue, black, brown, or gray. Nodular melanoma are thicker than 2 millimeters. They do invade the dermis, and they undergo a vertical growth from the start. So these can be more invasive. And many times they're mistaken for benign growths like seborrheic keratoses, so it's important to understand clinical history for these because they are more difficult to detect. They can be darkly pigmented, pedunculated, with symmetric borders, but again, they do invade the dermis. Lentigo maligna. This is something that happens on chronically sun-damaged skin, and they're tan to brown macules that gradually change over time. So these can have asymmetric foci of pigmentation, color variegation, and the incidence in the U.S. is rising, particularly in the older population. They can have this kind of slowly evolving peripheral margin extension and then potential central regression. The time of progression really, though, is 10 to 50 years, so it can be difficult to diagnose in the early stages, even for an experienced dermatologist. They can mimic solar lentigines, sunspots, flared seborrheic keratoses, and pigmented actinic keratoses. If you were to be evaluating this in the office, a biopsy really is pertinent, so referral at this point would be a good idea. Excisional biopsy is acceptable with narrow margins. You can do a partial biopsy, which a punch or an incisional biopsy is acceptable for larger lesions. Acral lentiginous melanoma, this accounts for less than 5% of melanomas, but 75% of melanomas among non-white populations. This would be your palmar, your plantar, and your subungual surfaces. And they start off as dark brown, black, irregularly pigmented macules or patches. And in the subungual phase, they can be arising from the nail matrix. So you'll see this longitudinal band, which we'll talk about, as well as maybe some nail dystrophy. And this is often, again, where a dermatology consultation is necessary for proper diagnosis, because this can mimic other things. So melanonychia, as seen in acral melanoma, the thumb and the big toe are the most commonly affected sites. Periungual skin will have pigmentation, and this is known as Hutchinson sign. They have this radial growth phase as well, which is highly suggestive of melanoma. When you see it under the dermatoscope, you can see kind of this irregular color, spacing, and thickness. In children, as a general rule, nail melanoma is exceedingly rare. Most times, pigmentation is due to a nevus that's under the nail plate. So the biggest thing to distinguish between nail melanoma is a subungual hematoma. So you're going to want to ask the patient about a history of trauma, duration, and whether, when you look at it, does it look like a circumscribed dot with red, purple, or black pigmentation? That may be more suggestive of a subungual hematoma. If it moves distally too with the nail as it grows out, then that may just be more of that sign of trauma. Melanonychia related to melanoma under the nail is generally not going to grow out. So now that we've kind of touched base on the most serious skin cancer to evaluate for, let's touch base on some of the other things that you may see that are non-melanoma skin cancers. A 54-year-old male patient comes to the office with a chief complaint of a pink tender lesion on their left temple. He states it's rough, he can pick it off, and then it comes back. Based on this description and the photo, what is the most likely diagnosis? I'll give you all a few seconds to just kind of think it over. So it's C, actinic keratosis. So these actinic keratoses, they're cutaneous lesions that arise from a proliferation of atypical epidermal keratinocytes. They're on a continuum with squamous cell carcinoma, and they arise as erythematous macules or scaly papules, fair skin, or people with chronic sun exposure, as well as in the sun-exposed areas. These are very common areas that they'll pop up. Immunosuppression is a big reason why people develop these, so transplant patients, particularly those with solid organ transplants, transplants, like kidney transplants, they're at higher risk for developing these. I liken them to pulling weeds. They'll keep popping up from sun exposure and time, and you can pull each individual weed with liquid nitrogen in the office or do field therapy with topical chemotherapeutics. So I've listed out different treatment modalities. If you were to do field therapy, that would be for a patient who had numerous lesions on their scalp, on their face, maybe on their chest even. So this field therapy, when you see it, you would want to do 5-fluorouracil. 5-fluorouracil is an antimetabolite. It inhibits DNA synthesis and cell proliferation, resulting in tumor necrosis. How you would want to treat this would be twice a day for 2 weeks. The patient will go through this cycle of erythema, blistering, erosion, and then reepithelialization. Studies have shown that there's greater than 75% reduction of actinic keratoses compared to baseline when doing it this way. Alternatives would be imiquimod, which upregulates cytokines, and it's done 1 to 3 times a week for 12 to 16 weeks. So it's a longer duration of treatment. And then studies have shown about a 50% reduction of lesions compared to baseline. Other things that we may use in office would be photodynamic therapy, which you would apply a photosensitizer to the face, and then the patient would leave that on for this incubation period of 4 hours. Then they undergo illumination with red light or blue light for approximately 16 minutes. And this has a great result. About 91 to 100% of actinic keratosis will clear at that 12-week mark, but they may require subsequent sessions. So it's really just based off of what a patient can tolerate. Squamous cell carcinoma. This is, again, a malignant tumor arising from epidermal keratinocytes in photodamaged skin, particularly in patients with more lightly pigmented skin. This type of skin cancer can be more difficult to assess because it can take on the formation of any benign lesion. Papules, plaques, nodules can be smooth, hyperkeratotic, ulcerated, etc. And although it's more commonly seen in photodamaged skin with lightly pigmented skin, it can appear anywhere on the body, including areas of chronic inflammation like scarring, anogenital regions, and mucous membranes. When it's seen in the anal or the periungual region, it can be related to high-risk HPV infections. Mucocutaneous areas like the lips, the genital, as well as perianal regions tend to be more aggressive, and metastasis rates can be as high as 30% in this. Actinic keratoses as well, they can transform into squamous cells over time. Although the risk of transformation is low, it's something that should be on your radar, especially if somebody has had a thicker lesion that hasn't remitted with liquid nitrogen over time. Keratoacanthoma, this is a subtype of squamous cell carcinoma, again, seen in chronically damaged skin. And I've shown 2 photos here, one in more lightly pigmented skin and then somebody with more skin of color, to kind of just show you that these can take on various appearances. When you see this, a shave or a punch or an excisional biopsy is appropriate for diagnosis. If you were to do a biopsy in the office, it should extend to the mid-reticular dermis to allow for evaluation of any invasive disease. More superficial biopsies can be misdiagnosed as squamous cell in situ. When you're also doing a biopsy, you should provide the pathologist the anatomic location of the tumor, the size of the lesion, risk factors like immunosuppression, radiation therapy, or solid organ transplant. So again, these keratoacanthomas, they kind of pop up very suddenly and they can involute over time, but they have this typical appearance with their craticiform, they have this central keratotic core, and you can biopsy these to the mid-reticular dermis. Okay, so let's talk about something else that you may see. A 40-year-old female, no significant past medical history, comes to the office with an enlarging bump for the last 5 months on her left nasal labial fold. She states that she has tried to manipulate it, thinking it was a pimple, no fluid ever came out. Upon inspection, it's pink, it's shiny, and it has some vascularity. What's the most likely diagnosis? So B, basal cell carcinoma. Basal cell carcinomas are the most common form of skin cancer, and they're most commonly seen in Caucasians. They arise from the basal layer of the epidermis and its appendages, and they can be related to chronic UV exposure, especially in childhood, tanning bed usage, immunosuppression, arsenic exposure, and genetic mutations. 80% are found on the head and neck, and they relatively have a low metastatic potential, but they can be very destructive locally. And there's 3 different presentations, which I've shown in the photographs here on this slide. So it's based on the histopathology, nodular, superficial, and morpheoform. So nodular, this is your pink or your flesh-colored papule with pearly, translucent quality to it and those telangiectatic vessels. Another clinical variant is where the papule has a rolled border and the periphery is more raised than the middle, and there's ulceration typically seen. And this is termed a rodent ulcer oftentimes. Superficial, which is your middle photograph, these are scaly, thin plaques with light pink or red color. The center of the lesion can have an atrophic appearance, and they're often more discrete in appearance. And then lastly, morpheoform. These are less commonly seen, and they're typically smooth. They have light pink or they're thin papules or plaques with frequent atrophy and an indurated quality with ill-defined borders, which you can see on this patient's cheek. Oftentimes, you can diagnose this with clinical observation, but however, I use a dermatoscope often in the office, and that actually really helps with diagnosis as well, because there's lots of different mimickers, which I've listed out here. You can do a shave or a punch biopsy, either is acceptable to evaluate for these. And then treatment modalities, your standard surgical excision with 3 to 4 millimeter of margins, that's the standard of care. Mohs for lesions on the face. And then for my older populations who have kind of low risk basal cells, I offer them curettage and electrodesiccation. And then second line therapies, again, the imiquimod and the 5-fluorouracil are both FDA approved. If you were doing imiquimod, you would do this 5 times a week for 5 weeks until there was that target reaction of erythema, crusting, scab formation. I find that patient compliance for this is a little lower because it's very painful for them, but histologic clearance is about 83%. If you're doing 5-fluorouracil, you would do it twice a day for 4 to 6 weeks, and often these patients develop an exuberant inflammatory response in that 2 to 3 weeks. Radiation therapy is a therapeutic option for the treatment of high-risk basal cells in patients who are poor candidates for surgical intervention. Again, prognosis for this is great with primary low-risk basal cells. Tumor is slow-growing, metastases rarely happen. 15% of patients with one basal cell will subsequently go on to develop another primary basal cell, so they need to get in with a dermatologist to do annual skin checks. We'll talk about some other benign lesions of note that you can kind of see on clinical appearance. The biggest thing with these when we talk about them would be unexpected or rapid changes in appearance. So check for bleeding, itching, if they're painful, and if so, you would want to biopsy these. So first one would be acrocordons, which are skin tags. They're outgrowths of normal skin. They're pedunculated. They have these thin stalks, often seen more commonly in patients who are obese, have diabetes, or are pregnant, and they form in sites of friction. So the axilla, the neck, the inframammary, or the inguinal regions. Generally, if you were to remove these, insurance doesn't pay for removal of benign lesions, but in-office treatment for irritated lesions can include local 1% lidocaine with epinephrine for larger lesions, and then snip excision with forceps and fine-grade scissors. You can also perform cryosurgery with liquid nitrogen, as well as electrodesiccation on low heat setting. Larger lesions, when you snip these, they do tend to bleed, so having aluminum chloride, electrosurgery, or silver nitrate in the office can help with coagulation. Dermatofibromas, patient may say, oh, I've had this for many years. I had maybe a bug bite or site of trauma. And these are benign proliferations of fibroblasts, so it's just the way the skin heals. Most commonly, they're seen on lower legs of females following shaving your legs, for instance. If you were to push on them laterally, they can have this central dimpling, which is called the dimple sign. And under dermoscopy, you can see kind of this star-like shape. Removal is really not advised for these lesions because the scar can look worse and they can come back the exact same way. Seborrheic keratoses, you may have seen these already. They're well demarcated, they're round or oval in shape, they have various color forms, brown or black, and they often look kind of stuck on and verrucous. The surface is dull and there's plugged follicular orifices in this, and they can be seen on the trunk most commonly, and they follow Blaschko lines, so it gives that kind of Christmas tree pattern that I've shown in the photograph. And they are seen more commonly in the older population, older than 60 years old. I tell patients it's from sun, time, age, and the pathogenesis is really poorly understood. A few variants of note, if they're small, white papules on the ankles or the dorsum of the feet. They're known as stuccokeratoses, and then dermatosis papulosa nigra. This is seen in darkly pigmented skin, and they can develop these small brown to black papules on the face and neck. The quintessential example of this is Morgan Freeman. And then the sign of lesser triolet. This is a sudden appearance of lots and lots of seborrheic keratoses, and this can be associated with GI and lung malignancy. Epidermoid cysts, these are asymptomatic dermal nodules with a central punctum, and they're freely movable. Really, treatment, you don't have to do anything. If they're inflamed or ruptured, you can inject them with triamcinolone, and if it's fluctuant, you can perform an IND in the office. If it's not inflamed and the patient just wants it out, excision is appropriate. You can even do a 4-millimeter punch biopsy, express the fluid, and really removing that capsule around the cyst is the most important thing. Cherry angiomas, these are capillary proliferations that are common, dome-shaped. They don't blanch with any pressure, and treatment, again, is not necessary, but if the patient wants them removed, you can perform electrocautery with or without anesthesia on a very low setting. You can do a shave excision with cauterization because these do bleed a lot, laser therapy or cryotherapy. Lipomas, they're the most common benign soft tissue neoplasm. They're painless, and they can grow rather large, greater than 10 centimeters, and malignant transformation is rare. However, if the lesion is rapidly enlarging, it's firm, it's painful, biopsy is indicated to rule out liposarcoma. So really, those are the things that I would say you would most commonly see as your benign as well as your malignant lesions in the office. So let's transition. Let's talk about things that itch. And we'll talk about psoriasis first. So for the purposes of this lecture, we'll focus on the more common presentation of chronic plaque psoriasis. There's different subtypes. So you'll see guttate psoriasis, you may see pustular psoriasis, and erythrodermic psoriasis. But your chronic plaque psoriasis is the most common. And these are well-demarcated erythematous pink plaques with overlying silvery scale. If you were to scratch at these, you'll have pinpoint bleeding underneath, and there are various comorbidities to screen for with these patients. Plaque psoriasis, when you see somebody with a new onset of this, you're going to want to look at their drug list. Are they on any beta blockers, lithium, anti-malarial medications, immune checkpoint inhibitors, TNF inhibitors, because those can all cause a flare-up of the psoriasis. Ironically, TNF inhibitors, even though they're used for the treatment of psoriasis, they have been linked to development of psoriatic-like eruptions. There is a variant of psoriasis called guttate, which is abrupt appearance of multiple small papules and plaques. They're less than 1 centimeter in size, and they have kind of this drop-like appearance, and they're seen on the trunk and the proximal extremities. Oftentimes, they're from patients who had streptococcal flare that was not treated adequately. Chronic plaques, if you see for plaque psoriasis, they'll be on this extensor surfaces and symmetrically distributed. So elbows, gluteal cleft. If you see somebody with inverse psoriasis, that may be where you'd see involvement of the umbilicus, the palms, the soles, the ear canal, but those oftentimes have a wider differential diagnosis. I won't go over too much on this slide with psoriatic arthritis, but if I see a patient with chronic plaque psoriasis, I do tend to screen them with these questions here just to see if I need a rheumatologist on board, because joint disease and the progression of it can be often very debilitating for patients who have understand that. When you see a patient in the office, delineate whether their psoriasis is mild, moderate, or severe. Moderate severe psoriasis is 5 to 10% body surface area. And if you're calculating body surface area, it's your entire palmar surface, including your fingers, of one hand, and that's approximately 1% of body surface area. So if you were to do 10 palms, that would be 10% of your body surface area. So primary goal really is control of the disease, and you want to tell these patients, psoriasis is not contagious, because a lot of times they feel very embarrassed or ashamed that they go out in public and people think that they're judging them for their skin disease. Localized plaque psoriasis, these you can treat with high-potency topical steroids, and oftentimes they have very good response. Ointments are more potent than creams. You can add in vitamin D analogs like calcipotriene or calcitriol, and topical retinoids oftentimes for people who are a little leery on topical steroids, so tazarotene. If they have any facial or intertriginous involvement, I tend to stick with non-steroidal options like topical tacrolimus or pimecrolimus. And really, you should be doing 2 to 3 weeks of active use of that high-potency steroid twice a day, and then switch off to the non-steroidal as maintenance. Moderate or severe disease, this is really where the derm referral may be necessary. You can do other things like biologic therapy. That's generally the next step when patients have tried and failed topicals or systemics like methotrexate, cyclosporin. Biologic therapy requires screening for the ideal patient. There's a whole myriad of biologics available right now. IL-17 of note is not meant for patients with underlying history of Crohn's or ulcerative colitis, and anybody who starts a biologic must be screened for TB annually, hepatitis B and C via lab work. And then lifestyle and insurance will dictate a lot of which biologic you can use. They all have different dosing cycles as well as loading cycles, but I just thought I'd mention some of the more commonly used ones here. Scalp psoriasis, this is something that you may see sharply demarcated kind of on the occipital region of the scalp. Intralesional corticosteroid injections are acceptable, but these patients may do really well with fluocinolone or clobetasol shampoo, foam, or spray. These are better vehicles than thicker creams or ointments to apply on the scalp. And then there is a newer therapy. It's not necessarily new. It's a Premolast. It's a phosphodiesterase 4 inhibitor. And this is really great oral therapy for patients with just scalp psoriasis and not really any involvement anywhere else. And no laboratory involvement is required. So let's talk about things that look like psoriasis, itch like psoriasis, but aren't psoriasis. First one is seborrheic dermatitis. This is a condition where you would see fine, greasy scale confined to more of the eyebrows, the nasolabial folds, the chest, and the postauricular area. It's chronic, so it will continue to happen over time, and it can be from changes in weather, changes in stress. Colder, drier months tend to have more of this, and it's an overgrowth of Malassezia yeast that we all develop on our skin. It can have an overlap in appearance with psoriasis, which is termed sebopsoriasis. Psoriatic lesions are sharply demarcated with erythematous and thicker scales, and they tend to be more abundant with kind of that silvery white scale. Extensor surfaces are favored, and you may also see classic nail findings of pitting or oil spots that you would not see in seborrhea. Seborrheic dermatitis has a prevalence in HIV patients as well as patients with Parkinson's disease. And if you see a patient with it on their face or on their scalp, you can do treatments with antifungal properties. So even shampoos, you can start with pyrithione zinc over the counter or selenium sulfide. The key, if the patient is doing it on their scalp, is to have them work it into a lather, let it sit for about 10 minutes on their scalp prior to rinsing it out. You can alternate it on the scalp with a salicylic acid-based shampoo for a thicker scale. If you were doing it for the face, topical ketoconazole is my go-to twice a day until it goes away, and then they can use it as maintenance therapy just once a day. Atopic dermatitis, this is a chronic inflammatory skin disease, more commonly seen in the children population, but it also affects adults. Often patients will have an elevated serum IgE level and a personal or family history of atopy, which is eczema, asthma, allergic rhinitis. They can have these excoriated pink plaques with hyperpigmentation and scale, and lichenification is very common. It lacks that coarse scale and well-defined borders of psoriasis. So here you can kind of see in the antecubital fossa, this is a little bit more lichenified, a little bit more ill-defined borders, and it's seen on skin flexures more than the skin extensor surfaces. Infants can have scalp and facial involvement, but their diaper area is spared, which is important. Special considerations for my skin of color patients, they are actually more dark or brown violaceous discolorations, more so than the pink and the red that you may see in lighter skin patients. The skin can be pretty dry in appearance with post-inflammatory hyper or hypopigmentation. So really the biggest takeaway with atopic dermatitis in infants 0 to 2, it's red, it's scaly, it's crusted, generally seen on extensor surfaces like the cheeks as well as the scalp, and it spares the diaper area. Children and adolescents have more of the classic flexural distribution with the antecubital, popliteal fossa, volar aspect of the wrist, the ankles, and the neck. If you see lesions in the axilla or the gluteal region or the groin, that's when you're going to want to consider more of the psoriasis, allergic contact dermatitis, or seborrheic dermatitis. A subtype of atopic is dyshydrotic eczema, which is hand and foot. It's often seen in people who wash their hands there a lot or do wet work. And these people may have small or itchy vesicles confined to the lateral aspects of their digits, which are termed tapioca balls, as you can see in the picture here. Treatment, topical corticosteroids is the mainstay, especially for mild or moderate disease. Ointments, again, have less risk of irritation and they're a little more potent. So if you are giving a patient a topical steroid, short bursts really should not be feared. The risk of this is skin atrophy over time. Topical calcineurin inhibitors don't have the risk for that, so you can alternate them. In office for the pediatric population, topical crisaborole 2% has been approved for children 3 months and up. This tends to burn, so if you have samples in your office, I would apply it on the child while they're in the office just to make sure that they can tolerate it before you send in the prescription for it. Mild or moderate to severe disease, again, this is probably where you'll want to send to dermatology unless you feel comfortable, but injectable dupilumab can be really life-changing. This has been approved for children 6 months and up. And really, you want to make sure that you're doing adjuvant treatments at home to really kind of nail down this atopic as well as prevent flare-ups frequently. So topical emollients throughout the day between corticosteroid use, bleach baths, which you can take 1/4 of a cup of plain bleach and put it in half a tub of warm water, or a half a cup of bleach in a full tub of warm water. Soak for 10 minutes, rinse off, and then apply, your topical corticosteroid or your topical emollient, and that just helps to improve the skin microbiome. Kind of shifting gears here a little bit, let's talk about scabies. This is an intensely pruritic eruption with involvement on the sides of the webs of the fingers, wrists, axilla, areola, genitalia. Symptoms tend to begin 3 to 6 weeks after the primary infestation, so you'll see lesions like small erythematous papules that are excoriated. You can even see burrows in thin serpiginous lines on the volar wrist. Usually the back and the head are spared unless it's in very young children. If you were to, think that maybe somebody had a scabies infestation at home or involvement when they come to the office, you can do a skin scraping, and you want to check an area that has the best yield. So you're going to look between the fingers, the sides of the hands, flexural wrists, elbows, axilla, groin, breast. That has the best yield in adults. In kids, if you're doing a scraping, that may be the palms, the soles, or the torso. So you'll take a 15 blade, you'll scrape the surface of the skin onto a clean slide, and then add a small amount of mineral oil and a cover slip. And then under the microscope, you'll look for this really cute little mite here, eggs or feces. If you see that, or if you suspect it, your first line of treatment is topical permethrin. So you're going to do it the neck down. Offer 2 treatments spaced 1 week apart, and get under the nail beds. Tell the patient to put this everywhere, between the buttocks, everywhere. And then oral ivermectin is an alternative treatment for non-pregnant patients. I tend to treat whole households, even asymptomatic close contacts, and then you're going to want to have the patient wash their clothing in very hot water, as scabies can't live off of human skin for more than 2 to 3 days. And then anything that can't be washed should be tied in a trash bag and left alone for about a week or so. So last thing that we'll kind of touch base on is common skin concerns in the primary care setting. And our first one is tinea. So there's 3 different variants that we'll go over: tinea versicolor, tinea pedis, and tinea corporis. Tinea versicolor, as the name suggests, it's a common superficial fungal infection that presents with hypopigmented macules on the trunk and upper extremities. It's not truly a dermatophyte infection, as the name suggests. The causative agent is Malassezia. So the risk factors for this would be hot, humid weather, hyperhidrosis, topical skin oils, and recurrence is very common in this. Your treatment would be your more conservative measures, like ketoconazole 2% shampoo. You can leave that on for 5 minutes. Do that once a day for about a week or so. And you can also do topical ketoconazole twice a day for 1 to 2 weeks. You can alternatively, if you wanted to just start with over-the-counter, use selenium sulfide shampoo. You would put that on the area that's involved, leave that on for about 10 minutes, and then wash it off every day for about a week, every month, basically, as your maintenance. If they have refractory disease and it's not going away, you can do oral fluconazole once weekly for adults for about 2 to 4 weeks. Tinea pedis, there's two different types that we'll talk about. Interdigital tinea pedis, so if you suspect this, check between their third and fourth digital spaces. You'll see this kind of macerated appearance, and it's due to direct contact with the causative agent, which is trichophyton rubrum. Risk factors for this would be walking barefoot in locker rooms or swimming pool facilities, diabetes, wearing occlusive footwear can also make you predisposed. Moccasin type, this is diffuse hyperkeratotic eruption on the soles, medial and lateral surfaces of the feet. So you can kind of see it almost looks like he's wearing a sock. Id reactions, if you see this is autoexematization. They're pruritic papulovesicular eruptions distant from the site of the tinea. And patients, they can have this on the hands when the tinea is on their feet, and vice versa. So if you clear the dermatophyte infection, the id reaction will remit. Tinea corporis, this is pruritic. It's circular, oval. They have this hyperpigmented scaling that spreads centrifugally. T. rubrum is most likely the causative agent, but it comes from direct skin contact with an infected individual or an animal. Central clearing often follows, and then the active advancing raised border remains. So that's what you can kind of see in this photograph. And then extensive tinea corporis may prompt underlying immune disorder like HIV or diabetes. I pulled this slide from Up to Date just in case, you do a KOH prep in the office, and then how to, go about with your treatment plan. A lot of patients that I see in the office for refractory tinea infections, they've been given prescriptions for topical steroid that includes an antifungal component, so it's clotrimazole and betamethasone. But often this can make the tinea look worse. The topical steroid can reduce that inflammatory component, but then once that's discontinued, the tinea will continue to flare. So as a general rule, if you are suspecting tinea, don't prescribe any topical steroids. Just go through with the antifungal treatment, and then you can always switch to a steroid if it doesn't improve after that. Again, you can start with OTC, over the counter, versus prescription. There's a whole list of things twice a day until resolution. I would recommend treating about 1 centimeter of normal skin around the tinea as well, just to cover for any microscopic components. If the infection is more related to candida, so your intertrigo, under the breast sort of thing, you would want to do nystatin cream for 2 to 3 times a day. And then, cyclopyrox solution can be used as a nail lacquer for patients with onychomycosis or suspected onychomycosis, but this is something that would take a really long time to see improvement, and the studies have shown that the actual rate of clearance is very low. For patients, you can do oral therapies too, which I've just kind of listed out, and that you can review too at your leisure. Let's talk about some acne vulgaris updates. So this is an inflammatory disorder of the pilosebaceous unit. So this is the hair follicle and the sebaceous gland. There's a whole host of why it can develop. So follicular hyperkeratinization, increased sebum production, Cutibacterium acnes, bacteria, hormones, inflammation, high glycemic index foods, as well as milk have shown that acne can become worse. If you look at a patient, you're going to want to grade them as mild, moderate, or severe. Mild, you would see kind of scattered, small comedominal or inflamed papules and pustules without any really associated scarring. If they're more moderate or severe, you're going to want to see those deeper cysts that are painful for the patient, those nodules, involvement of multiple body areas, and these tend to have very deep scarring. Female pattern, this is where the acne would really be confined to the jawline, and it flares with menses. General rules for patients who are being treated: tell them not to pick because the scarring is way more difficult to treat than actual acne itself. Any topical regimen you start them on takes about 90 days to see improvement, and the compliance is key. Gentle skin cleansers should be utilized rather than any soaps or scrubs, and they really should stop any excessive scrubbing of the skin. For mild acne, depending on patient compliance, you can start them really with just a topical retinoid, which is the mainstay of treatment, and this helps to normalize follicular hyperkeratosis as well as the formation of the microcomedo. If you want to start with something over the counter, adapalene 0.1% gel does not require a prescription. There's different name brands that you can get over the counter, and that's all you really need for a patient. Depending on compliance, you can have them start a gentle cleanser and a retinoid in the evenings, followed by a cream or a gel moisturizer. Pea-sized amount should be applied for the whole face 2 to 3 times a week at bedtime with moisturizer on top as tolerated until they can start building up to every night. They will go through kind of this dryness and this purge phase of their acne, and it should never be applied alongside benzoyl peroxide. However, if a patient is able to tolerate both a morning and an evening regimen, I like to incorporate either a salicylic acid cleanser or benzoyl peroxide 4% cleanser in the mornings, followed by a thin layer of topical clindamycin lotion. Moderate or severe variants, again, this may be where you want to consult dermatology. Again, you would want to do both morning and evening topical therapies, but you can also do a short course of oral antibiotic therapy, which we want to be good stewards of antibiotic use, but doxycycline tends to be my mainstay, 100 milligrams twice a day for 2 to 3 months, really to kind of bridge the gap between when they're starting their topical regimen to see the efficacy to that full 2 to 3 month span. You can use oral isotretinoin, which can be life-changing for the right patient, but if you were to start this, you must stop doxycycline 7 days prior because of the risk of pseudotumor cerebri. Oral spironolactone in my female patients can be life-changing as well. I always screen for menarche at least for 2 years before I start this medication, and 50 milligrams to 200 milligrams daily, I titrate them up. Most of my patients live at 100 to 150 milligrams, and you're going to want to screen them for hyperkalemia, kidney disease, and hypertension. They can't get pregnant while they're on this. Speaking of pregnant population, there are certain things you can use and certain things I would suggest you do not use. Azelaic acid can be kind of a great option for people who are having recurrent acne flares and hyperpigmentation, topical clindamycin and erythromycin. I'm very conservative as when I give oral erythromycin, but if a patient is really, really suffering, they can go on that safely. Less than 2% salicylic acid, and then less than 4% benzoyl peroxide. Definitely no to the tetracyclines, and then definitely no to the oral isotretinoin. Pittosporum folliculitis, you may have heard this. Social media has kind of termed this as fungal acne, and this you may see in kind of your teenage population. They're pruritic, they're monomorphic follicular papules on the face, neck, chest, back. Central face is generally spared, and it's an overgrowth of malassezia in the lipophilic regions of the body, or from overuse of topical antibiotics or topical steroids, as well as immunosuppression. It's really not related to any form of fungus. It's, that malassezia that's overgrowing, and it's not necessarily acne per se, but really to differentiate it from your typical acne would be that it's itchy and it's monomorphic. And if you do topical antifungals, this will generally go away. Perioral dermatitis, which is the last thing that we'll kind of touch base on, is a condition where you may see multiple small inflammatory papules around the mouth, the nose, the eyes, and it's on the spectrum of rosacea. Pathogenesis is poorly understood, but you want to get a really good history from these patients because their triggers are oftentimes what will clue you in as to why this rash is happening. Use of topical steroids on their face, heavy moisturizers or cosmetics, steroid inhalers, and fluorinated toothpaste. The fluorinated toothpaste actually tends to be the most likely culprit. Management, really eliminating that offending agent. So again, that stems back to a good history, and discontinue any makeup or cosmetics until they're clear. Wash with a gentle cleanser that's fragrance-free. If they have mild disease, you can start them on topical calcineurin inhibitors like pimecrolimus 1% cream. Insurances can be kind of finicky about covering for branded pimecrolimus, so alternatively, you can use topical antibiotics that may be a little cheaper for the patient. Again, twice a day for about 4 weeks or until they're clear. This tends to come back if you don't give them an adequate amount of treatment. So for more moderate or severe disease, I add in oral antibiotics for about 8 weeks, and that really knocks it out. So doxycycline is my go-to. But again, you can use oral erythromycin for people who can't take tetracyclines. That's really everything that I have for you today. I know we covered a lot of ground, so I really thank you for your attention. These are my references, and then this is my sweet little family. I actually married another graduate from LMU 2016. He's in the audience today. He is a joint surgeon at Jenny Stewart as well. And these are our 2 little kids. Thank you.
Does anyone have any questions for Dr. Hall?
Okay, cool.
I'll ask a question.
Thank you. Oh, you have a question?
I'll ask a question. The keratoacanthoma, how do you treat that, or do you just leave it alone?
Say that one more time.
The keratoacanthoma?
Yeah.
How do you treat it, or do you just monitor it?
Excision. I mean, if it tends to involute over time, you can monitor it, but if it's biopsied proven keratoacanthoma, excision. Yeah. Okay. Thank you.
We'll take about a 5-minute break.
2, yeah, 2, hey, yeah.
Amy's texting. Anne Marie Zeller is currently an associate professor of family medicine and osteopathic medicine and medical director of sports medicine and student health at LMU-DCOM. She is one of the team physicians for the LMU Rail Splitters and medical director of the Covenant Knoxville Marathon. Dr. Zeller serves on the board of directors and is a fellow of the American Osteopathic Academy of Sports Medicine. She is a graduate of the Des Moines University College of Osteopathic Medicine, where she also completed a predoctoral fellowship in osteopathic manual medicine. She completed a residency in osteopathic family medicine at University Hospitals in Cleveland, Ohio, and integrative medicine at the University of Arizona. Dr. Zeller also completed a fellowship in primary care sports medicine at University Hospitals, Regional Hospitals, and Rainbow Babies and Children's Hospital in Cleveland, Ohio. She has served as team physician for several large events, professional, collegiate, high school, and youth teams in Cleveland, Chicago, and Pittsburgh. Most recently, she has been one of the team physicians for Lincoln Memorial University Athletics. Her research and clinical interests include the effects of early youth sports specialization, injury prevention, medical education, transgender athletes, percutaneous tenotomy, and regenerative medicine. She is board certified in family medicine and sports medicine. Please help me welcome Dr. Zeller.
Okay, I have a booming voice. So I'm glad we do kind of the derm pictures in the morning to wake you all up. We had a very nice derm lecture right before this, so this will be exciting to kind of add on a little bit to what the previous physician was speaking about. Most of this review it's a little condensed into the slides, so I apologize for that, but I did want it to become like a reference for you if you had to like switch and quick go through stuff, like in a clinic setting. So we're going to recall dermatologic conditions in the athlete population, And I'll throw a few little caveats in there that some of us might have run into in a practical experience. Review the treatment options of those conditions in the athlete population. And then the biggest thing is return to play. So we have a lot of students that, especially collegiate, that go home and they go back to their primary care doctor during the summer, the break, things like that. And there are some medications and decisions that you'll have to do as their primary care physician and be able to articulate either in a letter form or a note form to be able to say when they started a medication, what's the dosage, how long have they been on it. And then also to consider that some medications are considered banned by the World Drug Organization. So you have to understand a few of those things. Not say you can't treat them, you should treat them, okay, but documentation is everything for a lot of these athletes. Now, bacterial infections, we love them and hate them. So the first big one is impetigo. A lot of our high school athletes that have equipment, especially straps that go under the chin, or they're shaving, things like that, you're gonna see impetigo, and it's usually, what I see it's usually like an irritation of the skin, and then the bacteria creeps in. So, or they'll do the classic, with this one, though, it's pretty much shaving. They'll shave, and then they'll introduce a bacteria that way. It's superficial. It does need to be treated. If it's very little, just a little spot, you can do the muprosin for, make sure you do it for 10 days. And then we've got our nasal carriers. And penicillin allergies should get zithromycin, and then widespread we still do cephalexin for impetigo. So what are my sort of thresholds for releasing somebody return to play? I'll show those kind of in a nice little chart, like towards the end of the bacterial section. So you'll have it in one nice chart to be able to see. Cellulitis, so we see a lot of this. In my personal experience with cellulitis, it's usually staph or strep. It's painful swelling. A lot of times I'll see it in association with they went to get their nails done, okay, and their toes and their nails, and they introduce an infection there, or they try to remove their own infected toenail. So you'll see cellulitis kind of in that respect. Also, really in these athletes, opportunistic infections run rampant. So if somebody's got a fungal infection, you treat it and they show up with something else in that area, it was an opportunistic infection for the most part. Usually, a lot of times if you think towards a lot of athletes that play all year round, right? What are the things that set you up for infection? Lack of sleep, poor diet, poor mental health, those all sent you up into. So you see a lot of this actually towards the end of the season too. So treatment, cephalexin, and then zithromycin for our penicillin allergies. Now we got the big one here, which is MRSA. And then everything in athletics is considered MRSA until proven otherwise, okay? It's the classic, I woke up with a spider bite, okay? A lot of it, they'll say, oh, it's just a pimple, and I tried to like pop it, and it didn't pop, it didn't produce any fluid, and then it gets huge really quick. So you'll have them pop the pimple in the morning, and it'll be huge in the afternoon when you see them in their training room. So it usually starts small, and then again, usually in my experience, they try to pop it, and then it gets really angry and upset. Now, this is the bane of a sports medicine doctor's existence, okay? Because MRSA is everywhere. It's everywhere on all our athletes. So that's why I say this is different than the general population. This is people who are in sweaty contact sports, not the best hygiene a lot of times, okay? And they're wearing equipment that may cause friction that can introduce bacteria. So you kind of have to think about it in that way. So risk factors, person-to-person contacts, so that's our athletes. They don't clean their razors. So let's say they had an infection, they don't switch out their razors. Again, turf burn, we see a lot. Hot tub, if it's not cleaned properly, the hot tubs are kind of gross sometimes. Even if they clean it daily, twice a day, people are going in and out of the hot tubs a lot. So you have to think about where the vector is that they're getting their exposed. Do I always do a gram stain and culture? Not really. A lot of times it's just a clinical diagnosis because of the population. I can't assume that it's usually going to be MRSA, staph, or strep. So I go ahead and treat them with clindamycin. And as you know, with clindamycin, if you hit people hard with it, you have to discussion about C. diff. So make sure you have the discussion. No excessive amounts of treating people with this. So if they keep getting recurrent infections, what I do is there's two things that they can do. And family members actually make the family members or the close partners do this if they keep getting recurring infections. Besides treating them with appropriate antibiotic, is you take about a cap of bleach a week and put it in a hot tub, not like a hot tub, but like your tub at home, and that is enough to reduce the amount of reoccurrence by about 75%. So that's actually a really good infectious disease thing to do for people. I know at baseline I'm infected, so I have to do a cap full a month. Penicillin allergy, you know we love our azithromycin, okay? And then you've got Bactrim. If I love Bactrim, Bactrim treats everything in my world and in the sports world, but Clinda is also an option. If you can get away with the topical ointment, please do it, but for the most part, it doesn't work for completely treating it, but it is great for prevention. And where it's stated in this slide is the miprocin to the NARS, okay, treatment. So if they keep having reinfection, you're probably going to have to treat them with the NARS, which is twice a day to the NARS for 2 weeks. Folliculitis, furunculosis, okay? So folliculitis is small, furunculosis is big. It really does show up a lot of places, especially hot tubs. So we call this like hot tub folliculitis. And so we have, it's usually Pseudomonas is the hot tub folliculitis, super itchy. We also see it, again, you're gonna hear a lot of this, it's hygiene related. So a lot of them don't feel like they need to bathe or shower for weeks on end, whether it's superstition or whether they just were never quite taught exactly how to have good hygiene, which is very reasonable in my 17 and 18-year-olds to not understand how to appropriately bathe as an athlete. So you have erythematous, super itchy, usually happens in the buttocks, axilla, belt line. Even around this time, you know, we call it like, I call it heat rash up in the north, okay? Super itchy, but again, it's all to do with moisture that's kind of sitting around and then introduces bacteria. Furuncles, you're going to probably drain them and do an IND. But that's dependent. So a couple things that we don't always think about is I do have athletes say, well, this isn't really itchy, but I have this like color change in my armpit. So on dark colored athletes, it can be lighter than their skin, but it can also be darker than their skin. So you have to approach it. And this is where I see, is this actually tinea? Or is this actually corynebacteria, okay? So which one is it? So we have to kind of decide, can we do a Woods lamp? We can, but for the most part, it presents pretty straightforward. And erythromycin can do well, but if it's just in the armpit, I will have them do like the topical washes. But just be cautious in our athletes that they may have really horrible insurance from out of state. And I will tell you, their athlete insurance does not pick up medical conditions. So make sure you consider the cost of some of these washes, because some of these washes are very expensive. So that's what I would plead to you is sometimes athletes can't afford the actual medication. Then we've got ecthyma, I never say that right, which is a deep form of impetigo. So this happens, you're using the topical, and then you keep seeing, get it more ulcerated, and then you can start to do the acetic acid soaks. So you completed antibiotics and they still have this weird looking lesion, then you want to treat them with this. And this is what I like. This is, I have the resource for this article that came out in 2022, but it breaks up the NCAA, and NFHS is the National Federation of High Schools. So if you just Google NFHS, you'll be able to find a high school form, which is pretty cool. And I call it the cheat sheet because sometimes you can't remember everything. But it has at the very bottom, tinea needs to be treated this long before you can return to play. MRSA needs to be treated this long before they can return to play. So I like it's like a little cheat sheet. But then I just wanted to show you that there are differences in NCAA. And again, as somebody who does NCAA stuff, I would appreciate a note saying as such that when they started medication, because they'll come back and say, I don't know when I started. What are you taking? I don't know what I'm taking. What are you taking it for? I don't know. That's really the answer that comes up probably 90% of the time. And so if you just write a note that says they're being treated for this, started on this date, but there's an NCAA form too. So if you get an NCAA athlete, you just type it in and you can fill out the little form, and that's easy for us to track. Viral infections. So these are the ones we're going to cover. Obviously, all these are super contagious. So again, these are a little bit tough to track down who's doing what, where, when, why, and how, especially in our population of students where, let me see, where this right here gets very confusing, okay? So we classically call HSV1 labialis, we classically see of the lips, and then we classically see this of the genitals. But let me tell you, with the current sexual practices within our adult populations, it doesn't matter. It's it's HSV2 or HSV1. It's going to get treated the same, okay? Gladiatorium is specifically a name we use for our athletes, and it's really a huge outbreak of all the areas on their pretty much face, armpits, arms, legs. So it's just a more extensive spread of the virus. Molluscum contagium, you can see this a ton in our little kiddos. Little kiddos get this a lot. And then obviously warts, which I'll talk about during the warts section. So herpes, primary infection. They have come in my office a lot, and they're like, I just feel awful. Will you test me for COVID? Like, I don't feel good. They get like that prodrome of like fatigue, worn down, maybe headache, maybe a little mostly body aches, and they'll want me to test them for COVID or the flu, which of course we do, because that's in our minds too. But then they'll come back a couple days later and say, these lesions popped up. So we do address them very quick and very fast, because again, this is very, very, very contagious in our contact sports. A little bit different, right, if somebody is your cross-country runner than if somebody is your wrestler, right? Cross-country runners don't notoriously do a lot of contact. So considering what sport they're in is important too. Flu-like symptoms, like I said, that's the viral prodrome. And then if you just left the rash alone, like it would go away in 2 weeks. So in men, it's not, I've seen it not be as painful as with women. So men sometimes ignore it because either they're embarrassed or, they don't want to tell anybody. They might get pulled from play. I don't know where to get that idea. Women have a lot more soreness and a lot more pain, so they usually present to us. And as we all know, it's activated with stress. So being a student athlete, traveling, doing all the sports, even in high school. I call this high school because we all know a lot of our high school athletes travel, and they don't actually ever get a break in life. But also, they have as a recurrent infection, they're usually shorter and a milder course. So that first course is really super painful a lot of times. Sometimes it just goes away and they don't think they have anything. A lot of times I've seen women think they have a yeast infection because it's super itchy and painful. So, you should do a vaginal exam. You don't need to do a full pelvic, but at least to observe the lesions because they look very distinctly different than a yeast infection. So making sure that you catch that. Herpes gladiatorium is, again, mostly skin to skin. We don't really, even though we spray down our mats like crazy, it's not usually transferred like mat to athlete. It's usually transferred skin to skin. So you see football, you see, obviously wrestling's the biggest one. And abrasive clothing, what that does is, again, it can cause irritation and cause an opening to the barrier of the skin, and then that herpetic infection can sneak in. Again, vesicles look very similar to what we're seeing here. Okay, so they'll think that's pimples. So again, making sure that you understand what each one looks like. Pimples don't just show up in patches of like 5 or 6 on the arm, right? So the face gets a little weird because they're shaving. Maybe they shaved over a pimple, so I encourage my athletes, this is what they'll do. They have an event on Saturday. They'll come in on Friday and say, I've had this for, 5 days. What do you think? I'm like, that's herpes, okay? But they're like, well, I've had it for 5 days. Like, why didn't you see me on Monday? So I really encourage them, any funk, we call it lovingly, the athlete funk, any funk that you have, you've been wrestling long enough to know better. So come and talk to me, call me up. I have some, send me pictures. I'm like, I know what that is, get them on treatment so then they could play on Saturday. So really timing is of the essence. I don't need to refresh you guys too much on the treatment, right? I need to refresh you on, like, if you have an athlete, high school, or this applies even to middle school, this is what kind of to think about. Again, herpes gladiatorium. For all the herpes, the SANK test is it's kind of old, but some people still use it. It's cheaper, believe it or not, than the PCR, but PCR's the choice. So again, it's clinical a lot of times. Yes, you have to look at it because it's a very distinctive type of lesion. I'm a huge fan. Acyclovir's like dosed 4 to 5 times a day, and nobody ever takes that correctly. So I love valcyclovir. That's just a preference. I don't get paid to say that, but I do like valcyclovir. Plus, it has a lot less side effects than our acyclovir cousin. Most effective within 48 hours of the onset of lesions. So if they get the prodrome, yeah, you could probably start them on it if you know they have, because a lot of people are like, oh, I feel a pimple coming on, they'll feel like, or I feel a lesion coming on, they'll say, I'm stressed, I know, I can feel it. I can trust them enough to start it, but if it's a brand new breakout, then usually most effective within 72 hours. Prophylaxis, I know a lot. I think USA Wrestling just gives everybody the prophylaxis because, I mean, at a high level of competition, you can't even risk that. And like I said, when I said side effects, acyclovir has a higher risk of causing low white blood cells versus the valcyclovir. But if you're worried, you can always check these on your athletes. This is the one that scares me the most, okay? When I see this, because again, a lot of these high school athletes and college athletes will have pimples on their face. And so sometimes it does just start looking like a pimple right there, right? How many people have had one right in their T-zone? But then you'll see the lesions start to go out through here. And again, they're usually in the dermatome. This one right here has to go to ophtho. So most ophthalmologists, even if they're busy, if you call them and say, I have a herpetic infection, they'll be happy to put you in. I don't know where you guys are at, but I feel like I can call some of mine in the region and get people in. Have I had to do that very much? Not really. I think maybe 1 or 2 in 10 years. But again, it's one of those things that makes us get a little upset to our stomach when we see it. So the return to play for specifically the ocular herpes is 5 days on antivirals and then 10 days for high school. And lesions can't be covered, then they can't have clearance. Okay? Oop, I went back. Oop. Now these are like These are the most annoying, but also the funnest ones to deal with because they're very satisfying to deal with. So it's a benign viral infection. They'll come in. A lot of times you're hearing little caveats from practice. They'll have tried to pick these off or something like that, and then it gets super infected, in addition to having also the virus. So it can be asymptomatic. It just pops up. It's mostly clinical. Like I said, I've never used the immunologic. I'd probably leave that to our dermatologic specialists to do the immunologic treatment, but they do just fine with curettage and cryotherapy if you have it in office, and chemical. So after that, I'll show you the return to play for some of these conditions. So we've got verruca vulgaris. We see it a lot on the hands, a lot on the feet, which is the plantaris, and it's the HPV virus, the non-cancerous type usually. So tell people, because sometimes they look up and they see HPV and then their mind goes to cancer. It's not the same virus. Well, I shouldn't say ever. There's never everything in medicine, but it's usually not the cancer-causing HPV. And again, treatment, same as molluscum, curettage it, or freeze it. Those are my favorites. Warts, because they're embedded, right, in the really thick keratinized tissue a lot of times, you do have to cut it back and then freeze it or curettage it. So cutting back dead skin shouldn't hurt. So athletes get nervous when I bust out the scalpel, but it really doesn't hurt them. You don't need to numb or anything. Just make sure, because you got to get that medication to the root. Otherwise, you're going to be treating it 9,000 ways to Sunday, okay? And then you can do salicylic acid. My favorite thing, and I learned this actually in pediatrics, is, and I have athletes that walk around with like duct tape on their hands for weeks at a time, but duct tape works great. Like I have them put a little bit of the over-the-counter wart removal and then just duct tape it just a little bit. And they don't believe me, but it works. But they have to do it. They have to do it for 4 weeks. Otherwise, if they just get bored and take it off after a week, it's not gonna work. So I make them try this first before I'll freeze it off. Unless it's in a place you can't cover with duct tape. So return to play, which is pretty nice for these viral infections. They don't need too much time off except with the HSV. So again, we talked about the biggest thing is that the lesions have scabs. That's kind of, and no lesions have popped up. So things to remember, if it looks dried out, scabby, they're probably on the back end of the infection versus like that vesicle, pustule looking sort of beginning lesion. And again, NCAA makes them be 5 days on antivirals, so they need to tell you soon and quick if they're in active season. Otherwise, they're just gonna be hanging out, waiting for treatment to happen. And I really do encourage my athletes that are skin-to-skin contact, like come talk to me sooner rather than later, because I can say, oh, it's just a pimple. Oh, it's just irritation from shaving, but wouldn't you rather have that stress off your mind if you could? Then we've got verruca vulgaris, which again, you can cover with a mask a lot of times, but again, wrestling doesn't allow that, so you're gonna need to make sure that they can at least cover it. A lot of them have it under their singlet for wrestling, which is the uniform they wear, and then you've got molluscum contagium. And again, they can go back to play pretty much right after you remove the lesion for the contagium. Same with warts. I just say sometimes if I do plantar wart stuff, they're gonna be pretty sore. so I give them the day off and then they can go back. Fungal infections. So the previous dermatologist covered some of these, so I'm not gonna go completely huge in depth. I just wanna give you little caveats to what I see in my practice. Is obviously we call it tinea, just a little bit of explanation of the definitions. So we have all these, pretty much usually the same, a lot of the same fungus is involved. And then I don't do a lot of KOH scrapings. I do have access to, mostly it's clinical again, clinical diagnosis. And then first line treatment, especially, I moved from the north to the south and I didn't know how humid it was down here. And I'm getting taught a lesson every day. So I do have a lot of athletes like for, sweaty, they wear their bras, like they don't wash their bras and then they get, like yeast infections. So it's fun to try and educate our athletes. But again, hygiene is the biggest thing to do. And then making sure they don't sit around in their uniforms. This is usually what happens. They have morning practice, they get out late, then they have to run to practice. They sit in those nasty clothes until noon, 1, 2, 3. So it's 4 or 5 hours of just that funk sitting on them before they can take a shower. So at the pro level, they have to shower and they have to use chlorhexidine wipes or chlorhexidine wash before they can even leave. So pretty funny story, when I was working with the Cleveland Browns for a little bit, we used to have these little chlorhexidine wipes, and they're like this big. Can you imagine a linebacker, how many he has to use to get his whole body like a playing card size? So then they're like, let's try the wash. So the wash works really good. So they have to do that before they leave. I can't necessarily enforce that at NCAA level, but I would love to. Ringworm, very classic. I know our previous dermatologist covered this, but for us, it's more important of when they can return. So again, I love the topical Lotrimin. A lot of people look it up, Google it, and they're already on it, okay? But they just didn't do it for long enough time. They maybe did it for a week versus the 2 weeks. So make sure you really tell them it's got to be 2 weeks, even if it's gone. What I see people's exposure to this is actually their dogs and cats. So a lot of this, we see it in the contact wrestling and football stuff, but I'll tell you, a lot of people I see it come off of their dogs and cats. And doesn't mean they're dirty, because they still get that opinion am I dirty? No, you're not dirty. Okay, so make sure to enforce that, but yes, enforce good hygiene. I very rarely put anybody on the oral, just because it can mess, obviously, with your liver enzymes. So if I do put somebody on it, I do check their liver enzymes. But it's rare, unless it's a whole body thing. Tinea capitis. This one's probably the hardest one to treat, especially in populations that have darker skin populations that have really thick, coarse hair, because that stuff is unrelenting. It does not want to go away. So what you'll see is a lot of our wrestlers will, if they're currently in treatment of that, they'll wear the cap that holds everything tight, and then their headgear over. That's allowed, okay? So if they're currently in treatment, because this takes 2 to 4 weeks, and 2 to 4 weeks of somebody's season is pretty substantial. So they have to have started it for about 72 hours, and they have to have it covered. So this is the big thing. When you look at it, again, you gotta make sure you check liver enzymes before you start and then after. The difference between alopecia and actual tinea capitis is that you'll see broken off hair. In alopecia, it's just, there's no hair there, period. You only see the roots. Versus in tinea capita, you'll see that it's broken off, if that makes sense. So you'll see right here, you can see it's kind of it's still there, but it's a little broken off. Versus alopecia, just there's no hair growth. Athlete's foot, everybody's probably maybe had this, before. It's very, very itchy. This is just hard to control because they walk around barefoot, they're icing and heating, and no matter how much we clean, and we do make sure we clean very well in our training rooms, they pick it up. You can pick it up at the pool, you can pick it up anywhere, so it's not necessarily a dirty thing, it's just exposure to stuff. And again, what I see the most is this heel. So the last physician spoke about this heel stuff, and it looks like super thick, dry, itchy skin. So it looks a lot different than the athlete's foot that between the toes. Athlete's foot between the toes, people say just really itches. It's kind of red and cracked in there. But it's pretty easy to treat, with antifungal powder. Some really great stuff over but again, what I see happen is they just get over it, quote unquote over it, and they stop the treatment at like 3 days. Been like, I feel better. I was like, no, you gotta do it for for like 2 weeks. The 2 weeks is the mark, okay? So you gotta do it for 2 weeks. It's more of an education moment. And we got jock itch. Happens everywhere. I'll tell you, most guys are embarrassed to talk to me about it. I don't know why, because I can really help them out. But yeah, so you'll see it in the folds. It'll be extremely itchy, which is different, okay? It looks way different. So this looks way different, and it's kind of dark on this side, than herpes does. So again, got to put your eyes on it. Don't assume what they're telling you is correct and not. Like, I don't love our patients, but they'll do anything to play. And if they think they have one little thing that won't allow them to play, they're gonna lie. So make sure you take a look at it with the correct permission and supervision. Now here's what happens, and I wanna bring this up, is anti-itch powders are not an issue in regards to drug enforcement, but cortisone creams are. So cortisone creams, oral cortisones, you want to be very cautious, not because athletes don't respond well to it, but that is one of the highly restricted medications. So make sure that you document, and you can Google the form, like it's called the medical exception form. Or you can just write a nice letter to me. I can do it for you if you don't know how to do that. But make sure if you put anybody on steroid creams, nasal steroids, okay, for allergies, things like that, make sure you document it so that they don't, what we call pop hot, test positive, because they will. And nasal steroids are not allowed, okay, at NCAA and the Olympic level, unless you have a therapeutic form to fill out. So all that Flonase, all that Nasonex, sorry, brand name, all the fluconazole, okay, that can make somebody test positive. So just make sure that if you know it's an athlete, that you just write a nice letter to me or their athletic trainer saying they're on this, and I can do the rest of the work. Tinea versicolor, our last dermatologist talked about this. Again, this is very common. It shows up on dark skin athletes as a light, and it shows up on light skin athletes as dark. So, but I've seen it reverse too. So it is very widespread. It doesn't really itch, and it's usually on the trunk. So somebody comes in and they get a rash on the trunk. What do we think in this current day and age? Do we think of something like, what? Measles, right? So like you come in, you're like, oh gosh, am I gonna see measles for once in my life? Like, no, so make sure you obviously check hands, feet, all that stuff, make sure they're sick. But for the most part, tinea versicolor, just like, hey doc, look at my arm, it looks like a weird color. And I really love the Selsun Blue, which is a selenium shampoo. It's great. Like, they can get behind the fact that they have to just wash their body with this Selsun Blue. Not trying to say brand names, but that's the one that comes to my head. But anything with selenium sulfide. And then ketoconazole cream. Our previous dermatologist did discuss that short term, you won't really get this pigmented changes. But I know a lot of people that have been treated for atopic dermatitis with topical steroids for a long period of time, dark skin people will start to get that lightening of the skin. So make sure if you're having to do this repeatedly, try to stay away from the steroids and have them choose the selenium shampoo first. It's cheap, it's easy, takes 7 days. So wash everywhere, not just where they see the rash. And then ketoconazole, some of us like to just be one and done, but I really save that to the very last, if they've tried the selenium, and I can believe they try the selenium, then I'll do ketoconazole ×1. So this one's actually the hardest one to treat. Does anybody do any like podiatry style nail care for seniors? So again, to really get this going, so you see thickening right here? That really does need to be like shaved down. So if somebody's coming with like super thick here, it probably needs to see a podiatrist, somebody that has a nail Dremel, not your person that does your nails, your mani-pedi, okay? They will do it sometimes. Actually, believe it or not, they do it. But I've seen people get a little too aggressive and break the nail bed, things like that. So if you have it, or if you're seeing a lot of it, nail Dremels, like $10, okay? And you actually can bill pretty good for nail dremeling, which is very strange. And so you need to do the topical, and it needs to go on for like 4 to 6 weeks. Okay, 4 to 6 weeks. Now you see some things out there like tea tree oil, and I'm a fan of tea tree oil. I think it's a great antifungal, but for nails, not so good, okay? It will take you 2 years of doing it every day to get that tea tree oil to penetrate. So the biggest thing, you gotta get the thickened nail down, just like you do with the callus, just like you do with the wart. You gotta get it down to be able to have the medication penetrate. And again, this medication's pretty expensive, so be aware of the costs that it may be for our athletes. So here's our return to play. And most of the biggest thing is the tinea corpus. If it can't be covered, they can't play. Okay, that's the biggest rule. Most of our athletes have uniforms that cover most everything or can be covered, and then they have to have be at least 72 hours on the antifungal, and that goes with tinea capitis. So this is the treatment, how long to treat it, but they can probably go back at 72 hours as long as they have the cap on all the time. If they can't keep the cap on all the time, they can't do contact play. Parasitic infections. Again, our previous lecture talked a little bit about this, is scabies. She did a good job about this. The biggest thing is just treating everybody that ever got exposed to them, okay? So you gotta wash all the linens. Maybe teammates need to participate in it, but it's the permethrin cream. And I tell people, like, just bathe yourself in it. Don't even put a thin layer, just head to toe bathe yourself in the cream, and I'll write as many bottles as you need, okay, for you to get treated. You can treat, twice. Sometimes I've had to treat people twice because they weren't quite as thorough with their lathering the whole body in it. But again, the treatment is actually prevented to going to other people. Pretty easy treatment for the actual athlete, but getting other people involved. And this, I've seen scabies come up because they travel a lot, and then a lot of hotel rooms. Hotel rooms can pick up lots of fun things. Okay. So avoid sharing equipment during that time, and then they do have to wash after their sports. And I'll tell you, hot water, if somebody takes a shower, hot water will make them extra itchy. So if they say like, oh, I get out of the shower and I'm just like, then you might suspect that they have. And at night, and then out of a hot shower, they'll really notice it. One thing I didn't know recently is that if you do draw on the skin and you wipe it off with an alcohol pad, the little like burrows, you'll be able to see them. I didn't know that. That's something new. If you don't have the skin scraping, you can do that. But obviously, you can do the skin scraping in office. It's pretty easy. Oh, this one gives me the creeps. This is fun. There's like, it's something that gives you like the itches, but body lice. I don't see this as much in our college population, but 100% in our younger population, our young kiddos. Again, you can do a skin scraping, or you can usually just look and see the little gnats and nits in the hair, and that is positive until you tell me it's not. Okay, so again, you can do the scraping, but a lot of times you don't need to. You're gonna see it. On there. And then again, permethrin, and I'm telling them, don't just do your hair, do your whole body, because your whole body has hair, so, and the whole family. Usually this is where you need to even treat the dogs, cats, all that fun stuff. And they can return to play in 24 hours. But I like to prove they actually did it, so they come see me first, and then I make sure that they have no other bugs moving around. I'll tell you, these little nits, they're supposed to brush them out, right? So when you do permethrin, you're supposed to like brush through with the lice comb. They'll have some little ones, but as long as you don't see little active ones everywhere, you're good to go to have them return. Mechanical injuries, so almost done. So abrasion, we talked about that. This is number one thing is I'm not really worried about abrasions. I'm worried about secondary infections. So just educating them about keep this clean. We do want to recommend on abrasions and cuts that after initial cleaning, you don't really need to put on a triple antibiotic ointment. There's a lot of people that are really reactive to antibiotic ointments. Just keep it clean, just keep it covered loosely, okay? We used to have the old adage of like, you gotta let it, take off the bandage and let it breathe. Well, we found that it actually delays their healing. Also using peroxide and alcohol after the initial cleaning delays, it actually kills the new cells that you're trying to heal the lesion with, or the abrasion. See this a ton in marathons. Like people will be bleeding down their legs and I think they're like bleeding from an organ. And I was like, and I'll be like, no, it just really, really hurt. So this one, I give a lecture to the athletes about finding the right sort of lubricant. So you got classic ones, like Body Glide, things like that are very, very important. And I think a lot of people, it's a texture thing. So when you put it on, you get pretty slimy. So for the most part, when I get feedback, they're just like, I feel so slimy and gross. And I was like, but every time you do this, you can't run for 2 days. So how about we just put it on and wash it off? So the best one, Vaseline. It's the best thing, okay? A lot of people have sensitivities to skin, but you can find a ton online that are pretty darn good. Acne mechanica is an occlusive folliculitis that I rarely see. Callus, and then we've got the classic runner's heel is what I call it. Okay. You can get that anywhere, but runners are amazing. I love them. They have like this mindset that I wish I had and I don't to push through all that pain. But they'll come in after a marathon and they'll have blisters. They'll have their toes cracked. Their toenails are falling off, like black and blue, and I have to do a little drainage of their nail to get all the blood out of there. So I admire them. Joggers' nipples you'll see, which is pretty funny it's not funny, but I didn't know men got this way worse than women because the friction of the shirt as men run, a lot of them ask me for Band-Aids and I'm like, why do you need a Band-Aid? He's like, I need it for my runners, joggers' nipples. I was like, okay, cool. Hey, whatever works for you. And then if you're covering a race, I always have Vaseline like on a stick, and I'm like handing it to runners so they run by because they know when they need the Vaseline. Blister, I tell people that if you're just gonna go home and poke an unsanitary needle in it, I'll try to drain some of the serous fluid out, but you wanna keep the covering of the top because that protects it from. But if it's a blister this huge, they're not going to be able to even walk home on it. So you should probably do them a favor and do a clean little drainage. Not a huge puncture, but you want to try to keep that top layer of the blister intact. Auriculohematoma, I may be a little bit strange, but I actually love doing this on our athletes because it's the one thing I can do in sports medicine that does make a cosmetic lasting effect to our athletes. But a lot of people, when you see this, they come too late, okay, so it's already started to solidify, or they think it's a pride thing. So like to have cauliflower ear, it's a pride thing, and I just have to say, okay, if we don't drain it, when you're 30, 40, you probably have to have this cosmetically fixed. And they say, okay, cool. And I say, okay, you're an adult. Cheers. But this is one of my favorite things to do. Black heel, you see that a lot. It's like the shearing forces, again, runners. Also our soccer players and our lacrosse players love to wear their cleats 900 sizes too small because they like to feel it nice and tight on their foot when they're kicking and running. So you'll see this a lot. It's just a friction of the epidermis and dermis rubbing together. golfer's nail. I would argue that I see this more in the, so this is for the hand, so they have golfer's nail in the hand, but they also have in your feet, and that's mostly runners, but they'll have a hemorrhage of the nail bed if they strike the turf, okay, and it can, that vibration can just even cause a nail injury. Ingrown toenail, for our athletes, I will allow our athletic trainers to cut back the nail a little bit, but for the full nail bed removal, I'll do that. And I usually wait, if they can get through the season, I'll wait to the end of the season because it does take you out for a couple days versus if you just cut the nail bed back a little bit and there's no real infection, it's just pain, then you can go ahead and try to at least manage their symptoms until the end of their season. Stretch marks, I see this a lot because people either they gain a bunch of weight to try and go from middle school to high school or high school to college. You want to obviously make sure with the sequela of striae that it's not due to obesity, not due to diabetes, not to the other metabolic things, adrenal issues that might cause this, but for the most part, it's mostly cosmetic. And there's just no treatment except reassurance. Okay. And that's it. Questions? Two minutes early.
It doesn't look like there are any questions. We can take a 10-minute break and then reconvene after that.
Dr. Neely is the director of the Breast Care and Research Center at Walter Reed National Military Medical Center's Murtha Cancer Center, heading the Department of Defense's only nationally accredited breast center. He is the acting chief, Division of General Surgery, leading more than 125 physicians, nurses, and staff specializing in trauma, colorectal, pediatric, oncologic, bariatric, and complex general surgery in the military's leading tertiary referral center. He holds dual faculty appointments in the Uniformed Services University's Departments of Surgery and Education as an award-winning educator and surgeon scientist. Dr. Neely is a 2014 alum of LMU-DCOM. He graduated from general surgery residency at the Walter Reed National Military Medical Center, during which he completed an American College of Surgeons Surgical Education Fellowship and earned his Master's of Health Professions Education from the Uniformed Services University. He is a 20-year veteran of the United States Navy, including deployments to the European Command and Central Command. He is a White House medical staff consultant for general surgery and breast care. Please help me welcome Dr. Neely.
Good morning, everybody. Really excited to be back in the Smokies. Kelly and I have loved our time living in DC for the last decade plus, but we miss the mountains, and so it's great to be back here. Dr. Whiting, thank you for having me and for having some of my classmates here too. We hope we're providing some return on investment for the chance that you took on us a decade ago. So the other thing I want to say as I'm starting is as a surgeon, as a specialist, I respect what you do. Going through my medical student rotation in family medicine, back in years ago, it just blows my mind and still does. The breadth of pathology that you see on a minute-to-minute basis in your daily clinics. And I wasn't trying to be cheesy with the frontline title here. I really do think that's true. You are the most important profession in medicine. Don't tell the other surgeons I said that. You are the most important position in medicine. I really believe that, and I wanted to come and be able to contribute to this conference, and so thank you again for having me. Oh, that button. Sorry, this is the big one in the middle, sorry. No, I'm not a Delta pilot. I'm an active duty Navy officer. What I say is not yet official policy for the military. I'm working on that. And if anybody has any financial disclosures that they want to help develop, I'm open to it. This QR code on the bottom right, we're going to use Poll Everywhere to hopefully participate a little bit while we're doing this. And so if you can pull that up, that'll be on a couple of these slides. So one of my goals today is hopefully to not give you any new information. I think this is probably stuff that you do as standard of care going through, and maybe just a reminder of guidelines and situations that you either do or don't see every day, and maybe provide some resources that you can hand to your patients. By the end, we can talk about an initial workup for any breast lesion that you have, figure out which screening guideline you are going to use and be able to give that to your patients, and then figure out who you need to send to your referral surgeons. 2 seconds on me. I joined the Navy back in 2004 as a line officer. Joined the Navy, see the world. I was expecting to go to Hawaii or San Diego. I got stationed at Augusta, Georgia, and then they sent me to Iraq. So I got to do some kind of high-speed things, and it was fun. But then after that, I decided I needed to be a doctor. There's a rheumatologist out there that doesn't get the joke. And so Dr. Whiting and crew took a leap on me, graduated at LMU, and was very excited to do that. Graduated residency at Walter Reed, and they said, thanks, you're a Navy surgeon. We found this really cool mobile office for you. It's got great views of the water. And then I found out that this is what they meant. And so I did that for a little while. But we got to do cool things like this is the Straits of Gibraltar. So as you remember, this is Europe on the left and Africa on the right. We're sitting in the Atlantic Ocean, and just over the horizon, about a mile yonder, is the Mediterranean Sea. So I got to do some really interesting things. Now I'm back at Walter Reed, where we see 150 or so new breast cancer cases per year, so that's 2 to 3 a week. And those range in age from the 90-year-old, 95-year-old patient who's a retiree or a spouse, all the way down to a 21-year-old newly diagnosed active duty service member. So we really do see the gamut. So this is just one more time, and if your QR code doesn't work, you should be able to send my name to that 22333. For online attendees, this should work for you too. No, I'm not being presumptuous with send my name to that. Poll everywhere wouldn't let me change it, so sorry. So just to see how this starts and get everybody used to it, who is in the audience today? Great. It's also good to see some trainees. That's awesome. Start going to these conferences early so you can see what it's like and start developing presentations that you can give later on. And then what do you do for the people that are in the room and online? Great, so full spectrum family medicine. And now the rheumatologist who works less than 40 hours a week jumped in. Great. Thanks. All right, so for our lecture, we're going to talk about breast concerns. So what happens when you see this on your clinic list? You like, I got this is fine. Is this, I'm going to go in and see what's happening and then figure it out? Or do you throw the referral slip right away? Okay, so we're confident or in the middle. That's great, and hopefully we can help move everybody up to the smiley face today. So this one should allow you to type in a phrase or two, and I would like to see what you think is required for a breast-specific history and physical. And hopefully as you type something in and hit enter, we should start to see some responses. Family history is a big one. Family history now goes out to a third-degree relative. So it's no longer just parents, siblings, children. It's aunts and uncles, nieces, your second cousin once removed, things like that. It is really broadened, so please take a wide family history. That's a big one. Family history of breast cancer. Also, please include prostate cancer, ovarian, uterine, cervical, even pancreatic or gastric, because some of the genetic mutations can have relationships to those. I like all of these, especially the GYN components, because that all talks, of course, to estrogen exposure, which is outside of family history, the single most important risk factor for breast cancer development later on. Having periods, meaning are they young, are they older, when did they start? I love it. Pain is a good one, we're going to talk about that. Occupational exposure, I really like that one, especially when you're talking either chemicals or please also include radiation, either as a medical treatment or as an occupational exposure. These are all great. Discharge is a big one. Please also, if you're asking about discharge, characterize it, spontaneous or only with expression. What color is it? Unilateral, bilateral? Please include all of those. Those are all very helpful. All right, this one is as much a pain for me as it is for my patients. I see some nods in the audience. So I'm going to ask you, for someone that comes in and says, yes, my breast kind of hurts, sometimes it's over here, sometimes it's over here. Somebody may say it's bilateral, often it's just unilateral, but it comes and goes, a little worse with menses, maybe not as bad, or maybe they can't say because often it just kind of hurts and I only notice it when it hurts and I don't. Is that letting you choose one of these options? See some yeses, some nos. All right, let's go back. So, sorry that slide's not working, but the actual answer here is any of the above. Does anybody know what the American Society of Breast Surgeons position statement for breast pain of any type, whether it's cyclical, non-cyclical? Can anybody quote that statement? Neither can I, because it's not a surgical disease. This is one of the patients that I see 2 or 3 of these patients every single clinic day, and these are patients that I really would encourage you to manage because there is no surgical treatment. I have one single patient in the last 10 years that I've done surgery on for breast pain, and she also had a high family risk for surgery, so we call it a risk-reducing mastectomy, but she had weekly debilitating, like in a fetal position pain for more than a year. We tried a whole bunch of things and couldn't get through it, but this is symptomatic management. Change the bra, go to a sports bra when you were wearing underwires, go to an underwire when you were wearing a sports bra, go to a bralette if you didn't have one of the others. NSAIDs, especially if you know it's coming on with menstruation, start them 1 or 2 days ahead of time, and you can even do Celebrex or something where it's a little longer lasting. Gabapentin 2 or 3 days before their menstruation, something. We don't know what causes breast pain. We think it's hormonal, sure, because especially the cyclical ones come around menstruation, but we got no idea. Often I will refer these patients back to either their GYN or their family practitioner, their IM physician, to try an oral contraceptive, even if they are postmenopausal, or if they're on one and they're premenopausal, to change the agent, because we know that there's some hormonal interaction with the glandular tissue, and sometimes just changing the agent will help. Sometimes starting one when you weren't on one, sometimes stopping if you were taking it. These are all things, and I tell them to try any therapy for at least 3 months, and if that's not working, then change to something else. The evening primrose oil that is halfway down there, that has some data behind it. It's an over-the-counter herbal supplement. You can get it for $10 at CVS for 1,000 pills. A lot of pharmacies don't stock it because it's an herbal. The data that's been done on that one is about 50-50. Some women get benefit from it, some don't, but there is 0 side effect. And so this is often one of the early ones I try if they're already doing Tylenol, Motrin, Celebrex, something like that, and they're not getting any effect. And I tell them to try it for at least a month, and if they get benefit, fantastic, we can high five. If they don't get benefit, then I've already told them that it's 50% effective and we can move on without me losing any credibility. Imaging for this one, I always do it just in case. The incidence of a bad lesion, meaning a cancer with breast pain, in practical terms is 0. There's like a 0.02% of finding an incidental cancer in a breast pain patient, which is actually lower than the general population, but it's out there. Often the patient is worried it's a cancer, and no matter what I tell them while they're sitting there, it's a cancer in their mind. Does anybody else have that experience? And so I lecture, thank you for all the hands, I agree. I lecture the radiology department or the radiology residency for a couple hospitals, and this is when I tell them they're getting an order for a therapeutic mammogram. And even when they call back and ask me, do you really need this? I say, no, I don't need it, but the patient needs it. And so we're gonna cure some of their breast pain with a mammogram, because once you tell them nothing's wrong and then you show them nothing's wrong, let me rephrase that, something's wrong because it hurts. Once you tell them there's nothing concerning, and then you show them there's nothing concerning, the pain seems to decrease. And I have a lot of patients that tell me that. So breast pain is something that if there's a specific structural concern, I'm happy to talk about it. Or if the patient, and I get this a lot, my primary doc said this was fine, but I wanted to hear it from the specialist. You get so many nods, yeah. So sure, I'm happy to have that conversation, but otherwise, this patient is probably coming back to you for therapy. Nipple discharge is normal. So let's talk about what the most common cause is. If you click on that one. Great. I agree. The most common cause is physiologic. This is a gland, it makes fluid, some of the bacteria from the skin walk up the duct every once in a while, so sometimes it's clear, sometimes it's serous, milky, green, blue, all of those totally normal. Even in men, you can get it once in a while, or men can have some discharge from the Montgomery tubercles, so the lubricating gland that is just around the nipple on the areola. Some men will come and say, I have this white bump, why do I have an extra nipple right next to it? No, it's just a gland. And they say I can squeeze it and get milk out. It's probably not actually milk, it's probably just some serous discharge. But normal. The one I need to see is bloody discharge. Bloody or rust-colored discharge. Management of that has changed. We'll talk about it in a second. But if it's bloody, spontaneous or not, please get an image and then have them come see me. Please don't send them to me first because I'm going to get an image and we're wasting time if we don't get the imaging first. Okay? Going back to that, the most common cause of bloody nipple discharge is still an intraductal papilloma. 90% of these are benign, and it's just the papilloma rubbing on the opposite side of the mammary duct. But through imaging and usually a biopsy, we got to prove that there's not a coincidental cancer. That has changed. Management, even when I was in med school not all that long ago, because we're still very young in our careers, right, Dr. Brown? We're still very young. Bloody discharge meant tissue in a bucket for an excisional biopsy. That is no longer the case. For expectation management, you can tell your patients that if the biopsy is done, it's just the papilloma, there's no atypia, and the bloody discharge goes away, they should probably still see a surgeon to talk about it, but we will usually get short interval imaging, 3 to 6 months, because if it's just the papilloma, it's often removed completely by a large core needle biopsy, and if there's no atypia around, that specific situation, the upstage rate is less than 3%. And so usually we just observe those patients. All right, from Dr. Hall's lecture first this morning, rolling right into this one, I thought it was a nice corollary. For skin lesions, my suggestion to you is use the 3-strikes rule. If it comes and you see a skin lesion, whether it's on the nipple like this one's actually Paget's disease. But if it's on the nipple, I see a lot in the intertriginous areas. I see, hey, I got this, and it won't go away. Often the patients have never tried anything even before they get to me. So I would suggest try one of the topicals that Dr. Hall talked about, whether it's an antifungal and you're talking in the yeast infection in an intertriginous area, use a steroid, use a something for a few weeks. If that doesn't work, switch to something number 2 and try that for a few weeks. 6 weeks is not going to make an oncologic difference unless you are seeing rip-roaring inflammatory breast cancer, which does not present as a little maculopapular rash. So you can try it. Even if it is, no kidding, Paget's disease like this, where there is a carcinoma underlying, that 6 weeks of trying topicals is not going to make a long-term difference as far as recurrence, disease-free survival, overall survival. So go ahead and give it a try. If number 2 doesn't work, all right, guys, this is funny. It's okay. You can laugh. All right. If number 2 doesn't work, then you need to biopsy it. And so whether that's a shave biopsy in the clinic, a punch biopsy, something like that, do that and get a diagnosis. The vast majority of even these are still going to be benign skin concerns. All right, I'm a surgeon. I have to start showing some gross pictures, so stand by. All right, this 35-year-old comes in, breastfed without problems 10 years ago, hasn't done any breastfeeding since. Mildly elevated temperature, heart rate's normal, mildly elevated white count. What would you do here? So it looks like an abscess, walks like an abscess, quacks like a duck. This patient who's not breastfeeding needs an IND. Right? There's abscess, there's infection under pressure, antibiotics are not going to penetrate, so please do this IND. If you're not comfortable doing that in the clinic, or if that's just not part of your practice, send him to Dr. Cope. He'll do it in the ER, and then he can set him up with you for a follow-up. I'm sure he'll be happy to bill for it. The difference for aspiration, somebody who is actively breastfeeding does not get an IND. Somebody who is actively breastfeeding does not get a scalpel in a breast lesion. What should be their first-line treatment? Now, I don't have a slide, but just in the room. First-line treatment for a lactating patient with a visible breast abscess. Observation is not the correct answer. I'm sorry? Antibiotics is possible, and you can still encourage them to keep breastfeeding. I would aspirate that, so just numb the skin, a large bore like a 18, 16 needle. What are we trying to avoid by not putting a scalpel in there? Yeah, they might stop breastfeeding. The bigger complication is a milk fistula, because now you're giving that low pressure system a diversion, and they will lactate through the side of their nipple or through the side of their skin instead of into the milk duct and out the nipple. So you're hurting baby and you're hurting mom, because once that starts and that becomes the path of least resistance, that won't stop until they're done breastfeeding. And so then some women will stop breastfeeding because that's so bothersome. They're soaking their bras, it's socially uncomfortable, then and they don't like it, and it predisposes them to more infection. And so that hurts baby, it hurts mom. So if they are breastfeeding, please aspirate first, throw on antibiotics if you'd like, if there's a cellulitic component, but aspirate first up to 3 times. If you've aspirated it 3 times and it's still coming back, then you can IND, or I'd be happy to see them at that point. All right, who gets questions on breast implants? Yeah. There are a couple updates to this over the last 5 years. So the biggest one is there is this rumor that my implants have to get replaced after 10 years. That is fake news. Alternative facts, completely nonsense. That used to be the case, and from the plastic surgery perspective, that is mostly an insurance question, where the global period for complications or reoperation is 10 years for most insurance companies. That is not an FDA recommendation. That is not a medical recommendation. That is not an ASPS, American Society of Plastic Surgeons, recommendation. If they're not having a problem, leave them alone. Many women choose to get these changed at the 10, 15, 20-year time frame because their body and their breast is different than when they had them put in 10, 15, 20 years ago. Fat content is different, gland size is different, the ligaments are starting to droop a little bit, and so they have them revised for cosmetic reasons, but this is not a requirement. One new suggestion from the FDA that came out in 2020 is implant surveillance. This is not oncologic surveillance. This is not an MRI to check on the breast tissue, but check on the integrity of the implant itself. Many women choose not to do this because it's tough to get insurance to cover that where they're looking at the implant. This is a differently protocoled MRI than a breast gland MRI, and so sometimes there's paying problems. Often I will get the implant MRI as the first line if someone comes in and says, hey, I have a burning that's starting in my breast, or a dull ache. It's always at one spot. It doesn't really change with menses, menstruations, so that you need to start looking for an implant rupture. A lot of the silicone implants right now are not going to leak. They're just going to break and open, but now the inside silicone is visible to your body's immune system, and you get a local inflammatory reaction, and that's that kind of burning that they see. So I would get an implant protocoled MRI. If you have an implant concern, get an image and then send them to plastics. Most general surgeons don't do revisional implant surgery. Most general surgeons should not be doing implant revisional surgery. There are quality measures that are suggested by the American Society of Plastic Surgery, so really suggest they go to a no-kidding, board-certified plastic surgeon. If there is a cancer concern, meaning you look at the implant and the implant's fine and there's still a mass, get an image, a breast image, not an implant image, and then send them to a surgeon. Please get that image first so that the surgeon has something to work with. The QR code here is for your reference. Those are the American Society of Plastic Surgeons guidelines. This is a patient-facing website, so that if your patient has any questions, they can go to that website and answer a lot of the things that you're going to tell them or the plastic surgeon is going to tell them in clinic. Any questions on that before I move on, or clarifications? Okay. This is probably the most common patient I see who doesn't already have a diagnosis. So standard imaging workup, or standard workup for any patient: complaint, get an image, and then manage it, right? For every breast complaint, and I can almost exclusively say that. Start with a mammogram, please. 35 and younger, please start with an ultrasound, just for breast density. Or it's always fair to start with a mammogram and let the radiologist tell you if they have a good enough technical picture. That's fine. It's a fair response for F. And you're right, that is my job. The great thing about this is that Dr. Snyder and his pathology colleagues or the radiologist usually tell you what to do for this. Atypical ductal hyperplasia does still require an excisional biopsy because, or why? Maybe I'll ask. Why do we have to cut that one out, or at least cut out more tissue? So that one, the cancer upstaging rate is still high. It's still in the 15 to 20% range that there is a cancer that was just missed as a sampling error because the needle biopsy that the radiologist does can't find everything. Fibroadenoma, radial scar. Radial scar used to require an excisional biopsy because of a cancer upstage rate. That is no longer true, mostly because our imaging is picking this up quicker. So the story behind that is radial scar is a gross pathologic diagnosis, and it used to be they cut out the cancer, and then when the histotech sectioned the path specimen, they said, oh, there's this radial scar, and so they thought the scar came from the cancer. Or they thought the scar caused the cancer. We found out that the cancer causes the scar, but our imaging picks it up so early now that the radial scar in itself is a benign diagnosis. Atypical ductal hyperplasia, any sort of atypia is a quality control problem for the body, saying that they let abnormal cellular components grow and don't eliminate them, and so that puts them at lifetime risk. This is more important than their family history. I'll repeat that. Atypia on a biopsy is more important than family history. It completely trumps that. Family history is calculated on a population level model. Atypical hyperplasia of any sort is physiologic for your patient, and so that's more important. This is maybe the third most important slide, or maybe the third most useful slide. So if you're looking at your phone or online, if you're sipping coffee, maybe look up at the slide for a second. And this is not my recommendation. The QR code on the bottom right is an older position statement from the American Society of Breast Surgeons. This is being revised, but I've sourced this here. If you get results from your biopsy of any of the things on the left, those are all completely benign. Those all need no change in screening or imaging plan. Those do not need to be removed, and those can just be observed in your practice. Many patients will come and ask me to take out a fibroadenoma. I'm happy to do that. I counsel them very clearly that there is no medical requirement for that to be removed. It does not increase their chance of cancer in the future. None of these do. Many patients just want it out because it's a lump, and breast lump equals cancer until it's gone from the body in many patients' minds. So I'm happy to take that. For possible excision, again, any atypical cells on a biopsy, defined as atypia, not benign lesions on the rest. But atypia needs an excisional biopsy. The possibility of a Phyllodes tumor needs excise to confirm that it's benign. And again, maybe the fibroadenoma per patient request. That's one of the few times as a surgeon when I just say I'm a technician, is if there's a fibroadenoma, if you want it out, sure, I'll cut it out. All right, the next set of slides, this is the most important part of the talk. Foot stomp, wink, wink, nudge, nudge, the most important part of the talk. So please, if you could jump in here. And I'm eager to see your opinion or in your practice what your thoughts are here. Thank you for not choosing E. Thanks, appreciate it. At least somebody's listening to me, I'll take that, okay? Why are these answers all over the map? They keep changing guidelines, and these are all correct. Each one of these is a different national guideline from a U.S. red-blooded American society of really smart people. The first one is NCCN and the American Society of Breast Surgeons. Second one is the American Cancer Society. Second one is USPSTF. That was recently updated about a year ago. Hopefully everybody saw that recommendation. The third one, I think, is the American College of Gynecology. No, D is American College of Gynecology and Obstetricians. C is American College of Radiology, maybe. Which one do you follow? Does this show up on your screen? This is a new slide for me. There should be like 7 different options where you can like touch on the screen. Where does that work for you guys? You guys are my guinea pigs for this type of slide. Yeah. Sorry, it's not projecting. I'll have to figure out why that's not projecting. All right, so a lot of NCCN, a lot of ACOG guidelines. I, as a breast surgeon, as the director of a breast cancer center, as a surgeon, period, as a husband, as a dad, I don't care. Pick one and follow it. As long as you follow that one completely, right? This is not one where you pick and choose. And again, these are all average risk women. I will emphasize that, average risk women. So, average risk women follow those national standard guidelines. High risk women need to follow NCCN. So, what defines high risk? What percentage here? It's actually a lower proportion of F answers than I expected. Good. So, using the NCCN guidelines, along with American College of Cancer Geneticists and a couple others, 20% lifetime risk is the defined threshold for high-risk breast cancer management. So that's when they need to go to a specialist center or go to somebody that sees breast disease frequently. That's when we start changing screening guidelines. We start adding in MRI. MRI is not a screening test for breast, period, for average risk women. MRI is not a screening test for average risk women. When you get into high risk, we start alternating MRI and mammography every 6 months. We start talking about chemoprophylaxis or medical risk reduction with tamoxifen and some of the other agents. We start talking about genetic testing, et cetera. So 20% on Gale model, Tyrer-Cuzick model, one of those. But that also means that I really rely on you to be risk stratifying your patients. It takes time, and I recognize that in your meeting with the patient, it probably isn't practical to do that. But I really, really strongly request that whether that's your input LPN or your tech or your front desk staff, somebody, for any woman 30 and older, or anybody that has any sort of family risk, please risk stratify these people. Pick a model and use the same one all the time. My personal preference is the Tyrer-Cuzick model because it seems to be a little more accurate once you get to second and third order relatives. But if you use Gale model because it's quick and easy and you can do it on a 3-question or a 4-question app on the phone, that's fine. There are some patient-facing resources out there where you can tell the patient, go to this website and click it in, and it'll give them a risk that they can then show you when you walk into the room. I don't care, but please do something. But 20% is that threshold risk. This down here on the right, that QR code is the NCCN screening guidelines. Those were updated in February of this year, I believe. And so that's what I tend to use because it's the most aggressive screening. I recognize that's my practice bias because I run a cancer center, and so I see all the bad stuff. And so I don't have a good feel for what might walk into your clinic on a daily basis. Again, please pick a guideline, stick with it, and check it periodically. Whether you make that a part of your practice pattern, that every July you're going to make sure you check the website and see if the guideline hasn't changed, something. Put that on your schedule so that you can do it, please. A note here about the transgender or sexual minority population. This population has always been there. It is becoming more prevalent in expression. The QR code here is the American Society or the American College of Radiology guidelines for transgender. There is not all that much data out there right now because so many of these patients are either afraid to identify themselves and go through screening, or it's not gender affirming for them. You have someone who was assigned female at birth or is genetically female and is now transmasculine, and getting a breast exam or getting breast screening, they feel it's degrading. It is still medically required. The American College of Radiology is, those guidelines surgeons and medical oncologists had an input into, and basically it boils down to if they still have breast tissue, they need screening according to regular genetically female cisgender guidelines. If they are male to female transition and they've had more than 5 years of hormones, they could start getting screenings. We don't have a ton of data to back that up, but we are seeing some rare cancers in that population that is higher than the genetic male population. So that's kind of what we've come up with at the moment. We assume that will change over the next 10 years as we get more data. If they are genetically female, assigned female at birth, and they've had a complete risk reduction mastectomy, they do not need screening imaging. They should still get a clinical exam once a year. That does not have to be by a breast specialist. That can be just in their annual well physical checkup. Top surgery or cosmetic surgery for a female to male transition is not a mastectomy. They do not remove all the breast tissue. That's a cosmetic surgery, so they're going for body sculpting. There is still enough breast tissue there that in conglomerate is often more than an A-cup breast. And so those patients have not had a risk-reducing surgery, and they still need screening. Again, this patient is shown to not utilize genetic gender aligning care as much, or they're afraid to go get it. More of these patients show up when they find a lump and they're coming after their cancer diagnosis. So it is a special population. I'd be happy to talk about that online, offline if you want, but this is the current only guideline that's out there, and it's mostly expert consensus. Here are two things you can give your patients. Both of these are a little wordy, but the American Cancer Society, that QR code, that's a website that they can go to. You can give that to them. It walks through everything. It's very good about what are the terminology, why should I do this or should I not, what should I ask my doctor, things like that. The NCCN guidelines on the left is like a 40-page booklet, but it's a lot of good information. It's a little more technically written, but it goes through everything. So options for you to give your patients. All right, I have 11 minutes left. Thanks, Dana. So a couple questions and then a couple case presentations. I love this. Good, yeah. Most of the guidelines, NCCN is my favorite, 40 years old. This is an average risk patient, right? She had menarche starting between 9 and 16, which is the numbers we use for risk calculators for the Gale model. That does not have anything to do with precocious puberty, anything. That's just what Dr. Gale used. She had first pregnancy earlier than 30, and thyroid cancer does not impact breast cancer risk. It doesn't impact genetic risk. So starting at 40. Reiterating my final statement for point E there, that screening MRI is not a test for average risk patients. All right, I'm a partial breast cancer surgeon for about half my practice. So the 2 QR codes here, the one on the right is the breast cancer treatment guidelines. I recognize that you are often not treating breast cancer in your practice, but you are the one that the patient knows, so they're probably going to ask you for an opinion. So that's the treatment guidelines. It's a whole lot of if this, then this, choose your own adventure type stuff. On the left, I put the NAPBC website. If at all possible, please send your patient with a cancer diagnosis to an NAPBC accredited center. There are quality metrics that they have to have, including the most important one is a multidisciplinary discussion of patients when they get their diagnosis. Most breast cancer surgery is not done in an academic center in the US. More than 60% is done in the community, which is great because it's a core skill for general surgeons for our residency, and this is fine, but there is some wacky jack going on in the community for surgeons who are not part of either an accredited center or at least go to a multidisciplinary care conference, meaning like weekly, monthly, something. Their patients are being presented, and they're getting other people's opinions on their patients. Surgeons who have a solo practice or a non-academically affiliated practice who don't do part of this, we see some odd stuff that is not guideline concordant because maybe it's how they trained 20 years ago, or maybe it's because this is how I like to do it. That is not the standard of care. So if at all possible, please send some of that. Especially in the military, once we do that accreditation, it's in every 3 years, we get exactly nil for reimbursement for doing that, but it is proof to ourselves and proof to our patients that we are in the top 10% we are guideline concordant, and 90% of our encounters and notes and stuff meet the international standard of care. So that's why I use that. So for every cancer, name it, stage it, treat it. Any cancer everywhere, especially breast cancer. I see your role as the name it step for this. Get a mammogram, get a biopsy, and then manage that biopsy result. And if it's cancer or something else, sure, send it to me. The 2 surgical options, in case they ask, for most breast cancers are lumpectomy plus radiation for small lesions, or mastectomy. For people who qualify for a lumpectomy, those are oncologically equal surgeries. So a lumpectomy plus radiation has the same recurrence rate, disease-free survival, overall survival as a complete mastectomy. As bonkers as that sounds, and there's even some early data that says lumpectomy plus radiation, because of the radiation, may have a lower recurrence score than mastectomy. Mastectomy does not always get your patient out of radiation, which is why many women choose that as an emotional response. And so I'm very clear when I tell them that it's based on the final pathology of the tumor. One of the other reasons that NAPBC accredited centers are great is all the other specialties that are there. So this is an emotional disease, so social work or mental health of some sort, physical therapy, there are a lot of other adjuncts that we help. All right, in the last couple minutes, so these are, I want to discuss some advanced presentation lesions here, okay? Any guesses as to what that one is? So this orienting, this is the breast, the nipple is up under the tech's hand. This is the chest wall down here with all the leakage. This is a necrotic lesion that's about 3 centimeters wide, and then because I had this patient, it was about 1 centimeter deep. Sorry? Squamous, that's a good possibility. It's on a differential. Inflammatory breast cancer as an option. Let's go back to this one. So this was granulomatous mastitis. This is not cancer of any sort. We find this in patients who have especially recurrent abscesses for no reason. They're often deep. They can often say, I had a dull ache for a while, and then I've had a couple of these abscesses drained in the last year. And so go down the cancer workup, just like every breast lesion. You get an image, then get a biopsy, and then go from there. So this patient had a big abscess here. You can't see it, but she had a healed incision from a big abscess there. These patients, there's often an underlying Corynebacterium infection. We don't know if that's causal or correlative, but these patients, if they can get through 2 years of treatment for the abscesses, it'll often go away. Or if they can get postmenopausal, it'll often go away. Sometimes it's just fulminant, we have to go to mastectomy. But a biopsy is key for this patient. What about this one? So this is a patient's left breast, nipple areola out here, and kind of hard to tell on the projector here, but this whole area is raised and firm, and then you have several hydra heads starting to poke out and 2 exophytic fungating lesions there that are connected by a little skin bridge that is almost gone. What's this? Or maybe I can rephrase, what would your first step be for this patient? Don't say referral. Who was going to say referral? Yeah, half the audience. Okay, all right, that's fair. What should you do at least at the same time you're ordering the referral? Imaging, thank you. This patient needs a diagnostic mammogram, right TF now. This patient, yeah, don't tell my mom I said that. So this patient had a sister with breast cancer that was diagnosed 6 months prior to this walking into my clinic. A month prior to the sister's diagnosis, this patient felt something in her breast, thought it might go away, as many patients do, and was going to wait for a month and then go have it looked at. Sister got diagnosed. This patient's words, I went into denial. I did not have cancer. I didn't want to have cancer. I couldn't do anything about it. And then once it started breaking through the skin, she knew intrinsically what it was, and then she felt such overwhelming shame that she hadn't done anything over the last few months that she couldn't bring herself to go get care. Her husband, who they had a good relationship, had not seen her bare skin in more than 9 months. And so he was sitting in the waiting room of my breast clinic while she showed me this, and he didn't know what was going on. He didn't know why they were there. He thought she was going to get a mammogram. So this is stage 4 breast cancer because she had mets to not only the axilla, but also lumbar spine. First step with this, if it had not been metastatic to the spine, she gets neoadjuvant therapy, so chemotherapy first. And actually through her chemotherapy, a lot of that lesion that you're seeing has resolved, and the skin with my wound care team has almost completely re-epithelialized. So they can get care and they can get a response, but we have to get started. This one I got as an ER consult. What is this one? Or possibilities? I'll tell you, this is not invasive ductal carcinoma, which is the most common in breast cancer. Snyder, don't talk about this one. This is what we talked about last night. So orienting, the patient's nipple is down here in a very ptotic breast. This open lesion here has a 3 centimeter skin lesion, and then bruising and necrotic skin, and then by palpation, most of the breast was taken up with a firm semi-fluctuant mass. So this one, yes, sir. Yeah. Extravasating methamphetamine infection. Great question, and we asked and we pushed hard, but that was not it. I have seen patients with similar lesions. This one was not. This was metaplastic breast cancer, which is a rapidly growing tumor that actually rarely metastasizes. Go figure, even with this look to it. So no matter what it looks like, the workup is the same. So she got a same-day mammogram and biopsy, and it was metaplastic breast cancer. Actually, yes, ma'am. Yes, it's incredibly difficult to tolerate the mammogram, and actually the mammogram techs don't like this because it gets their machine dirty, And some techs will say, we can't do this because it's an infection risk. No, clean the damn machine. This patient needs it. You can also do this under ultrasound or something like that. But this patient got a same-day mammography, same-day biopsy. Biopsy actually took like 3.5 weeks to come back because you can see this in melanoma that goes superficially deep. We finally decided through some genetic testing that this was breast that had then gone superficial. So in the 3.5 weeks it took to get the biopsy results back, the tumor went from what you see on the left to what you see on the right. And this is even with daily wound care and antibiotics to prevent superinfection. So this is on the operating table. She got this mastectomy and then went under chemotherapy. She had a great response to chemotherapy. And then her husband called us one Monday about 2.5 months after the mastectomy, said she had some pain in her back and was kind of tired, went upstairs, laid down, said she had kind of this tearing muscle pain and didn't wake up. So we think she died from a dissection. So this is my suggestion slide. Anything on the left, I would like you to send to your referring surgeon. The third line there, the high-risk patient who does not have a cancer, I said this patient may return to you because that patient does not need to be seen necessarily in a breast center every year. They get a treatment plan or a screening plan, and as long as they're not having new concerns and their genetics is negative, they get on a every 6-month mammogram, MRI, and you just follow the results from there. Anything on the right, I outlined in red, please risk stratify your patients so that we know what to do with them. And then my personal Matt Neely plug is I get probably once a month, send a breast center to evaluate if imaging is necessary. Come on. Please just do your job. So that's my summary slide. I'll leave this up there. I'm happy to take any questions either here or send them by email. I'm happy to respond. Thank you very much. Yes, sir. Sure. Can I comment on sentinel lymph node biopsy? Patients need a sentinel node biopsy with any mastectomy because it's not technically accurate after a mastectomy. And for any invasive cancer, with the exception that patients over 70 with low-risk tumors do not need a sentinel node biopsy because it doesn't affect their treatment. They're going to get often hormonal therapy. Very rarely they're going to get chemotherapy, and if they get chemo, it's based on the oncotype score, which is a genetic test of the tumor itself, not based on the axillary staging. So patients over 70 with low-risk tumors do not get a sentinel node in modern practice. It's the Society of Surgical Oncology Choosing Wisely guidelines for that. Otherwise, ductal carcinoma in situ, come to you next, sir. Ductal carcinoma in situ, doing a lumpectomy does not need one. The specifics of that have changed in the last 5 years. There used to be some high-risk features for DCIS, comedonecrosis, grade 3 tumor, something like that we used to do it. We found out that the complication rate was higher than the node positivity rate, and even that low node positivity rate was not affecting their oncologic treatment, so it didn't matter. Yes, sir.
I was just going to ask for the patients that have had top surgery, is that like, are you screening with ultrasound, or, I mean, is it kind of dependent on how much tissue remains? Because it seems like for some of those patients, like, I don't know if there's enough tissue there to actually do a mammogram.
Right, excellent question. So do we screen top surgery patients with what imaging? Those patients are probably the few that I would get an MRI. There are some centers that have ABUS, automated breast ultrasound. That had a lot of interest 4 or 5 years ago, but it hasn't really shown to have great sensitivity. So MRI is probably appropriate for those patients. But again, MRI is a screening tool in that specific population. MRI is not a screening tool for your average risk cisgender female with an intact breast. Yes, sir.
Just to follow up that one, because I do a lot of transgender care, is it yearly MRIs, or how would you do that?
So I would use the same schedule as whatever other guideline you're following for your genetically female patients. I go for annual because I follow the NCCN, but again, that's my practice bias because I'm in a cancer center and I see all these, and so that's the most aggressive screening. You may or may not get some insurance pushback on that, but usually saying transgender patient with incomplete risk-reducing surgery needs MRI because mammogram or ultrasound not technically feasible, you usually get approval for that. Dr. Cope.
First of all, I just want to say great lecture. Even as an ER doctor, being able to look at this stuff and feel like I have a decent understanding now of this stuff, I think is a testament to how you put it together. And I think we all appreciate your travel from the DC and Maryland area here to East Tennessee to give us this lecture. But I guess going back to the breast abscess thing, so to be honest with you, in the emergency medicine kind of guidelines, pretty much what we're taught is if it needs a scalpel, a surgeon has to do it. And like for us, basically the guidelines say, you know, especially something less than 5 centimeters, we can try like needle aspiration if you're comfortable with that and that kind of thing. But, you know, I guess I've never asked the question, honestly. I mean, is there anything special about draining a breast abscess? I mean, I know that obviously you worry about the cosmetic results after, you know, you drain a breast abscess. I think from an EM perspective, that is something we're sensitive to because I'm not a surgeon. I don't do this very often, so I am sensitive, you know, to the cosmetic outcome if I were to drain something like this. But I guess what other kind of complications do you worry about? Is there a special way to drain a breast abscess, you know, that kind of?
Sure, so tips and tricks for draining a breast abscess. I'll go back to a corollary for trauma guidelines, and cosmesis is a healthy person problem, just like, you know, the scar from a thoracotomy is an alive person problem, so if you need to do a resuscitative thoracotomy, you do it. Again, lactating females, please try 2 or 3 times to aspirate that abscess so you avoid the milk fistula. For a non-lactating patient with a big abscess, if it's anywhere near the areola, I would incise right along the edge of the areola because that color change and being a curved incision really cosmetically hides that well. Anywhere else, drain the abscess, because an infected breast that continues to get infected and then starts to get necrotic skin over top is going to be a much worse long-term cosmetic outcome than a small prick. Please don't use a 15 blade and just poke it, squeeze the stuff out, and then let it go. If you do that, at least make it a centimeter or so big and then stick a wick of like non-iodinated gauze in there, just because the iodinated stuff sometimes makes the skin react. And leave it in there, not as packing. I liked the previous point where you wick that abscess and just let the stuff come out. Otherwise, if you can do it at all outside the cleavage area where it's going to be covered with a bra, swimsuit, something, but wherever it is, you just got to do it. Try not to do it in a radial line from the nipple. Right, try to do it in some sort of circular orientation. Dr. Schneider.
So I've had a couple cases referred to me of axillary swelling and accessory breast tissue in lactating females. What's your management for that?
Sure, so redundant axillary tissue, this I put along the fibroadenoma range where there is no medical requirement to get that out. Sometimes people are worried about screening. Most mammograms, when they get their screening mammogram and they get the medial lateral angle, they will catch the axilla so that tissue is being screened. If it's really painful for the patient and they want it out, I will take it out. The problem is you can never tell how much you're taking out, and there are little tiny nerves like the lateral intercostal brachial nerve that's up in the axilla. So there's sometimes get a little neuropathic pain after that, and there's, from memory, like a 30% regrowth rate for taking out redundant axillary tissue. So I have that just as a frank conversation with the patient. I recognize that I am not the one having that pain or discomfort, and if they want it gone, I'll take it out. A well-informed patient is allowed to make decisions, in my mind.
Any further questions, Dr. Neely can be contacted, or we can collect those and send them to him later on. It is already 10 o'clock, so we'll take a brief break so we don't get too far behind before we start the next lecture.
Thank you.
Dr. Nicholas Kalinsky is a 2016 graduate of LMU-DCOM. He is board certified in internal medicine and allergy and immunology. He is a specialist in pediatric, adolescent, and adult allergy, asthma, and clinical immunology, and works at the Allergy, Asthma, and Sinus Center in Knoxville, Tennessee. Please help me welcome Dr. Kalinsky.
Thank you for the introduction. My talk's going to be a little bit different. I'm going to have photos of cats and dogs. It's going to be a little bit of a different vibe. Clinical Allergy 101. So my disclosures, so I'm a speaker and consultant for AstraZeneca, also a consultant for farming, as well as a speaker and consultant for Hikma Pharmaceuticals. Some of the objectives. So at the end of this activity, we'll be able to identify symptoms and physical exam findings of the allergic patient, understand when to refer a patient to an allergist, and then recommend environmental control measures and medications to prevent allergic symptoms and exposure to common aeroallergens, and then also recognize comorbid conditions in allergy and better treat the allergic patient. So common aeroallergens, so these are common things that people are allergic to. So trees, grass, weeds, specifically the pollen, it's not necessarily the bark or the leaf, mold, and then things like dust mite, cockroach, cat, and dog. So if an individual were to go to an allergist, these are most likely going to be the things that they will be tested to as far as things in the environment. So how does this happen? So an allergic attack is an inappropriate reaction by the body's immune system to a normally harmless substance. So in the example of maybe ragweed pollen, we become exposed to ragweed pollen, and there are certain individuals that develop IgE, or immunoglobulin E, which is the allergy molecule in the body, against that ragweed pollen. And then upon future exposure, that IgE is on the outside of mast cells, and when there's cross-linking between the IgE and the antigen, or the ragweed pollen, the mast cell will degranulate and burst, releasing histamine and other inflammatory proteins and cytokines. So this would result in stuffy nose, sneezing, cough, wheeze, headache, sinus congestion. You can have eustachian tube dysfunction, secondary ear infections. A lot of the times I see allergic inflammation in the nose and the sinuses. This leads to a secondary bacterial infection. These patients often go on antibiotics throughout the year and also oral steroids to relieve some of their symptoms. Of course, if you have allergies, you're very familiar with the fact that it doesn't make you feel that great, often causing you to miss work or school, and then messing with your sleep. If you can't breathe through your nose while you're asleep, it really does impact your sleep significantly. So inflammation in the nasal mucosa and conjunctiva of the eyes is occurs when the immune system encounters allergens in the air. In the community, this is often referred to as hay fever. Affects up to 40% of Americans and is a common reason for people to miss work or school, and is the most common cause for a visit to the primary care provider. So you will definitely see this in the office. And I think it's important to recognize symptoms and, of course, physical exam findings. So moving on to the physical exam, the nasal salute. So often whenever I see a patient walk into the office, I can tell within the first 10 seconds if I think that they're going to be allergic or not. They're going to have a nasal crease or a crease across the bridge of the nose from rubbing their nose often. Everyone's familiar with the allergic shiners or the dark circles underneath the eye. That's because of venous congestion and venous blood pooling underneath the eye. You can see there in that picture on the bottom right, the concha bullosa, all of this is connected as far as the vasculature. And so if there's venous congestion, you get that dark look underneath the eye. Denny-Morgan lines, which are those lines underneath the eye. And then you can also have tearing, of course, as well. So when does allergy season really start? So here in East Tennessee and surrounding areas, tree season is generally in the spring. Grass is going to pollinate during all the warm months of the year, but it's going to peak in the summer. And then weeds pollinate at the end of the year. So for some individuals, they could have symptoms all throughout the year, peaking during certain times of the year. And then mold is a year-round allergen, peaking in the spring and in the fall. And of course, if that weather system comes in, bringing a lot of moisture and heat, it's going to be worse as far as a bad mold season. So when to see an allergist? So I would say early. So before we move on to allergic rhinitis and conjunctivitis, I think that it's very important, especially with this group of people. There's a lot of severe asthmatics out there that have been in and out of your office going on oral steroids again and again, multiple times over the course of the year and for multiple years in a row. And as we all know, steroids play their role, but over time, and especially the cumulative dose effect of steroids, are bad for the patient. So we want to do everything we can to identify those really severe asthmatics that have been on multiple rounds of steroids, still have persistent symptoms even though they're on high-dose ICS or ICS-LABA. Beyond that, patients that have nasal polyps or congestion, sinus infections often, if they have a loss of sense and smell and taste, a lot of those severe asthmatics will have nasal polyps as well, so look in the nose as well as listen to the patient. And then, of course, your severe atopic dermatitis patients, those are ones that we would like to see as well. The medication landscape has changed for all of these conditions where now biologics, and of course not only in allergy and immunology, but in other specialties as well, is really coming to the forefront. And we have these incredible medication options for some of these patients. And so just remember that severe asthmatic or somebody with eczema, urticaria, all that kind of stuff, those patients should be seen. Of course, food allergy, if there's any question of food allergy, we should see those patients. There's a lot of people practicing allergy, but there's not a lot of people that know exactly what they're doing, I think, especially when it comes to food allergy. So we would like to see those patients as well. And then also your patients that have a history of COPD. You know, we're in East Tennessee and surrounding areas, and so many people smoke, and they automatically get labeled as a COPD patient. But in reality, many of those patients actually have underlying asthma as well, or there could be asthma-COPD overlap. So remember to look at risk factors, you know, family history of asthma, allergic sensitization to things in the environment, history of eczema, food allergy, elevated eosinophil count. All those types of things are very significant. And so get a really accurate history, and if you have any doubt, please send them to a board-certified fellowship-trained allergist so that we can help you make that diagnosis. Don't wait until the patient's trouble season. So generally, here in East Tennessee, spring and fall may be the worst for most individuals. So don't wait until that time of the year. I think that most of these patients, and especially if you have allergies, you understand what I'm saying, they have pretty severe symptoms. A lot of them are trying to treat themselves with over-the-counter medications, which are generally not that effective, especially when used incorrectly. So these patients need to be seen by a board-certified fellowship-trained allergist to get the appropriate testing, diagnosis, and an individualized treatment plan. So what happens? So of course, just like any doctor's visit, you want to get a really thorough history. The history is probably the most important part of any clinical exam. For us, if someone comes in, if we think they are allergic to things in the environment, we're going to skin test them most often. You can also do it through the blood, but it's technically not as sensitive of a test, so the best test is a skin test. We take that little plastic toothpick there on the bottom right, we poke the back a couple times, read that test after 15 minutes. Then for what's negative on the back, we do a more sensitive part of the test called an intradermal test, very similar to a TB test, which I'm sure we all have had. And then we read that test after 15 minutes, and it's the combination of the result of the testing with the history that results in allergy, not just each one individually. So it's not just that every patient is allergic or has allergic rhinitis or conjunctivitis. There's a lot of other reasons for these types of symptoms. As you know, of course, some infections can present very similarly, and then also occupational exposures can cause some symptoms, drug-induced rhinitis or rhinitis medicamentosa, hormonal changes, irritants, atrophic rhinitis, so as we age, the lining of the airway and nasal passages starts to change, either producing too much or too less mucus, and then gustatory or gustatory rhinitis, runny nose out the front when people are eating. So there's a lot of different reasons for why these patients may have symptoms, which is, again, why it's important that they see someone that is familiar with seeing these types of conditions. So the most common thing that people are allergic to is actually dust mite. Dust mite is a year-round allergen. No matter how clean we are, everyone has dust mites. It's a protein found in the bodies and the feces that we're allergic to. Dust mites are these microscopic creatures. They look kind of like an alien. They're technically arachnids, and they love to live in our pillows, mattresses, carpet, furniture, and stuffed animals, as well as clothing even. So as far as avoidance measures, so we get our highest dust mite exposure at night in our bed. The best thing that you can do is use dust mite-proof encasements that goes over the box spring mattress and pillow, and then sheets and pillowcases go over top. Of course, if you have carpeting, ideally you'd want to remove that, at least vacuum often. A dehumidifier is one of the best things for dust mites. The allergen for dust mite is actually pretty heavy, and so air purifiers doesn't really do too much. The dehumidifier would be the best. You want the humidity to be below 40%. That's because dust mites live off the ambient humidity in the air. So if you remove that, it's going to decrease your dust mite burden. For children that might have stuffed animals in the bed, you can actually take the stuffed animal and put it in a bag and then in the freezer for 24 or 48 hours, and it will kill the dust mite. The allergen will still be on the stuffed animal, but at least it will prevent them from multiplying. And then you want to wash the bedding and sheets once a week, at least in the hottest temperature possible, ideally exceeding 130 degrees. So pollen, so again, trees pollinate in the spring, generally. Grass pollinates during all the warm months of the year, but peaks in the summer. And then weeds pollinate at the end of the year. Here in East Tennessee, that's like middle of August until the first hard frost of the year. Those are seasonal allergens, and then you have perennial allergens as well. So things like dust mites, mold, cat and dog. So ragweed. So ragweed, you can see it there on the right. Here in East Tennessee, we have a really fierce ragweed season. Everyone seems to have symptoms in the fall. Again, that's middle of August until the first hard frost of the year. There's the pollen grain right there. It kind of looks like a spiky golf ball. And these pollen grains can travel hundreds of miles in the air. So it's not just Tennessee, it's surrounding states and areas where all of this pollen is collecting. So as far as avoidance, it's very hard to avoid pollen if you're going to go outside during allergy season. But you would want to change your clothes after being outside all day, shower before bedtime. If your neighbor is cutting hay and everything like that, you would want to maybe stay inside that day. I've had multiple people come in, and it's usually the next day they'll wake up and their eyes just swollen shut after playing outside all day, so that's something important to remember. If you're going to do yard work, maybe wear a mask or some shades to help prevent that level of exposure, and then as you're driving down those long highways, you want to keep your windows closed as well. So mold spores. So there are millions and billions of mold spores in this room probably right now, as well as outside, more so outside. Of course, mold likes those dark, damp environments, that hot and muggy weather, especially after a rain. Whenever that rain comes in, it actually causes these mold spores to burst, releasing even smaller granules deep into the airways, causing all kinds of symptoms. If you're going to do mulch or rake leaves and things like that, especially in the fall, be careful. We have a lot of patients coming in with secondary infections after doing yard work that has to do with mulching and raking leaves. As far as avoidance, so this is another example of the dehumidifier, okay? So dust mite allergy, mold allergy, the dehumidifier is better than the air purifier, okay? You want the humidity less than 40%. Of course, you want to eliminate any type of mold. You know, patients always ask, well, you know, what type of mold is this? And then they show me a picture. I have no idea. I can't tell just from that picture, but it doesn't really matter. You just need to tell them that whatever the mold is, just try to eliminate that. They can get a diluted bleach solution and then try to get rid of the mold that way. Getting their own dehumidifier. You want to remove mold sources like old carpeting. Whenever you go and steam your carpet, just remember that mold is growing underneath your carpet after that. Avoid raking leaves, at least without a mask. And then remember that when you bring in a Christmas tree, especially if it's that live Christmas tree, you are going to bring some mold into the home and increase your mold counts as well. So for pets, so of course, I'm not telling individuals to get rid of their pet, okay? I'm just giving them some strategies to try and decrease their risk for exposure to their pet allergens. And so it's not just the hair or the fur that we're allergic to, it's the dander or skin flakes, saliva and urine that cause allergic symptoms. And even if you were to remove the animal from the room or the home, it can take up to 6 months for that allergen to leave the home. So that's really important to remember. When you go to your friend's house and they put their cat away, it doesn't really do anything for you, okay, other than keep the cat from getting on your lap. And then cats are the worst, not just because I like dogs, but because the allergen is very light and buoyant, and so it stays in the air for hours. And it's very sticky, okay? So it sticks to clothing, and whenever children, say, for example, go to school and they have a cat or a dog, there's almost as much allergen found throughout the school as there would be as if the animal lived there. So pretty significant, and you can definitely get exposure that way. So you ideally want to keep pets out of the house, at least out of the bed, preferably out of the bedroom. You want to use a high efficiency, that's a typo right there, high efficiency air filter. And then remember that animal dander, even if the animal is kept in the basement, it can find its way up into other portions of the house. You want to bathe pets at least once a week, preferably twice a week. And again, it can take up to 6 months for the allergen to leave the room. And then this is probably one of the most important parts of the whole talk. There is no such thing as a hypoallergenic cat or a dog. That's all marketing, and so if you're paying, $5,000 for whatever that dog is, you got duped. Okay, so as far as mainstays of treatment, so avoidance, medications, and immunotherapy. So avoidance, we already discussed environmental control measures. Medications, medications play their role, but I think that they kind of serve as a Band-Aid, whereas something like allergy shots may be curative. And so just remember you're treating the symptoms, but not the underlying cause when you use medications. So some of these medications, so they're both over-the-counter and prescription. You can get the over-the-counter first and second generation antihistamines, and then of course you can get prescription like montelukast or anti-leukotrienes. On a scale of 1 to 10, this is really important, on a scale of 1 to 10, 10 being the best, oral antihistamines are like a 2 or a 3, nasal sprays are like a 7 or an 8. Okay, so patients do better with a nasal spray, not the allergy pill. Okay, and especially for symptoms from the neck up, montelukast only works in about 1 in 5 individuals. Okay, so different than asthma, but just for symptoms from the neck up, 1 in 5 individuals. So using a nasal spray is very important. The best types of nasal sprays are the combination nasal steroid and nasal antihistamines. So that's important to remember. It can be fluticasone, mometasone. It doesn't really matter too much to me. Azolastine and olopatadine, and then the combination nasal sprays are what I prefer, and I prescribe them early and often. And I get a lot of great benefit from those medications. Another thing that's important to remember is technique. It sounds really, really silly to say or think, but there's a correct technique on how to use a nasal spray. You want to aim away from the middle, so left side towards left ear, right side towards right ear. That's because the septum is highly vascular, and with the nasal steroids especially, you can get those nosebleeds as a side effect. And then you want to lean forward, actually, so nose to toes, chin to chest, not lean your head back. If you taste the medication, it's not staying in the nose. So I try to stress that with patients, and I usually give them a printout. It's a little blurb on how to use their nasal spray, and then try to cover that often with them. So immunotherapy, potentially curative. So there's subcutaneous allergy shots, which is most commonly done. And then there's sublingual tablets or sublingual drops. Allergy shots should always be given in the doctor's office. If they're not, or if your doctor is okay with you giving it at home, I would think about that and maybe think why that is, and maybe because a lot of the times those allergy shots are very diluted and a lot of it's placebo. I think that most allergy offices that you'll go to with a board-certified allergist, they will not let you do it at home because they use clinically effective dosing, and patients do have reactions, okay? Trees, grass, weeds, cat, dog, dust mite, mold, cockroach, that's what we immunize to most often. Maybe most ideal for the polyallergic patient or someone that's allergic to more than one thing. Typically done for 3 to 5 years, although we have some individuals that have been doing it for 50 years and they never want to stop because they know that eventually they'll lose that desensitization over time if they do stop. And then it's usually dosed every 2 to 4 weeks depending on the patient and their symptoms. Then you have sublingual tablets or drops. I would not typically recommend these to a family member, okay, because I don't think that the data is as great as far as its efficacy when compared to subcutaneous immunotherapy, but it is an option that we do offer to patients, especially individuals that may travel often and have a difficult time getting into the office. There are FDA-approved products for grass, ragweed, and dust mite. This is maybe most ideal for the monoallergic patient. Usually these medications are discontinued because patients, it's dosed every single day, and so some patients are not very compliant. And then also they have itchy throat, itchy mouth, or swelling of the tongue or the lips, and this results in discontinuation. As far as the duration, it's about 3 to 5 years as well, and again, dosed daily. So immunotherapy, so what I tell patients is that we're literally desensitizing you to the things that you're allergic to, and over time, starting at a very low dose and increasing to what's called your maintenance dose, we're giving you low levels of the antigen to ultimately decrease the likelihood that you would have symptoms and potentially get you off any medication that you're on. We use the example of an allergic asthmatic. If you treat the patient to what they're allergic to and desensitize them, they may no longer have that trigger and may no longer need their inhaler or any rescue therapy. Or in allergic rhinitis or conjunctivitis patients, they may no longer need their nasal spray or eye drop. It is the most effective treatment for allergy symptom relief. If you choose the right patient, and there's a lot of people abusing immunotherapy for financial reasons, but if you choose the right patient, it's effective in about 85% of patients, or even better if you are very selective. And immunotherapy is the only cure. So immunotherapy does equal disease modification. So early intervention in the pediatric population can decrease the risk of developing new allergies later in life. decrease the risk of developing asthma, and is potentially curative. So my home run pediatric patient that I love to put on allergy shots would be somebody that has eczema, their parents both have asthma, and they have rhinitis or allergic rhinitis symptoms that have developed. That is probably the highest risk category patient that may go on to develop asthma later. You want to look at some of these predictors, like, again, sensitization to aeroallergens, family history of asthma, history of eczema, the elevated eosinophil count, wheezing apart from colds, food allergy, all that type of stuff runs together. So just remember, and again, that goes all back to the history and figuring out, what could be going on with the patient. There's something called the atopic march. So where an individual may be born and have eczema, and then eczema is the primary risk factor for food allergy. Food allergy itself is not genetic, but risk factors are, and eczema would be that primary risk factor. And so it's eczema and food allergy that would be risk factors for things like asthma and rhinitis. These can flip-flop depending on which chart you're going to look at. But you can actually stop this atopic march, and the only thing that has been proven to do that is immunotherapy. Okay, so that's very important to remember. I think that will change with these biologics down the line, like early intervention with dupilumab, for example, which is going to be something for severe eczema all the way down to 6 months. That patient may one day be proven to decrease that risk of developing asthma down the line, kind of like immunotherapy. But for right now, immunotherapy is the only intervention that we can make to decrease the risk of developing asthma later in life. Very important to remember. So indications, so allergic asthma or an allergic trigger to asthma symptoms, allergic rhinitis, conjunctivitis, atopic dermatitis, and Hymenoptera allergy. These would be like the wasp, yellow jacket type of allergies. And so remember that we can test for these types of things, and this is an indication where insurance will cover that. Immunotherapy is safe, but again, we are giving these individuals something that they are allergic to, and so they do have reactions. Greater than 90% of reactions happen within the first 30 minutes after the allergy shot, and so we'll have patients wait 30 minutes in the office to be sure to monitor them for symptoms. Of course, you would want to look for symptoms like a skin rash. You would see that often. It's very common to have a large local reaction, like something right here. It's just going to be itchy and red, but not really going to be systemic. But some patients can have throat tightening. The highest risk patient is going to be the patient that doesn't report previous symptoms or that has uncontrolled asthma. So, of course, we want to ask them questions on how they're doing, which we'll get to here soon. No home injections. I really want to stress that. I would totally recommend against that. Epinephrine autoinjector, we generally prescribe that to every single patient. Although we ask patients to wait 30 minutes after their allergy shots, it's not a prison, okay? So they can leave. And so as a CYA, we do give them an EpiPen, although most of the time it's not necessarily necessary. Education is key. I feel like at least 70% of the office visit I spend educating. The 30% and everything rest, I'm getting the history and going over a treatment plan, but I really like to educate. I think it makes for better patient outcomes, and then also makes the patient understand everything that you're trying to do for them. So for immunotherapy, we get a consent form signed. If they have asthma, we get a peak flow at a baseline, and we want to look for a 20% drop from that baseline, and that would indicate that maybe their asthma is uncontrolled. The peak flow, and this just goes for general knowledge, the peak flow will drop even before symptoms present sometimes, okay? So that's why the peak flow is very important. It's very easy. It doesn't really cost you any money. You have your peak flow meter in the office, and so it's something that you can kind of trend over time and kind of watch patients for their asthma control, and they can even do it at home, which is very helpful. We always ask patients how their immunotherapy is going, if they had any reactions or any symptoms. And then regular follow-up, I think, is very key. I think we all can agree that regardless of the medical condition, regular follow-up results in better outcomes. And then I like to provide 24 access to medical care for each patient. So some take-home points. So allergies are common, okay? It can be a very, very common reason for why someone may come into your office. I think it's extremely important to consult a board-certified and fellowship-trained allergist. Again, there's a lot of people practicing allergy out there, but especially with food allergy, super dangerous to order serum IgE testing for foods. You're going to leave yourself confused and the patient even more confused, and then they're going to have them in my office, and then I'm going to have to make them unconfused. But it would be very helpful just for them to come see us at first. There's a high false positive rate sometimes, especially in someone that has really bad eczema with blood testing, and so very important to remember. We typically would test for trees, grass, weeds, cat, dog, dust mite, mold, cockroach. As far as aeroallergens, there are many effective treatment options. It's not just about allergy shots. You know, again, it's that combination nasal spray that you will find will be the best. 1 to 2 sprays each side twice a day with the correct technique. I rarely prescribe oral antihistamines. And then immunotherapy is preventative, safe, and is potentially a cure for many of these patients. And that's something important to remember. As far as what we do, so it's not all just about allergic rhinitis, conjunctivitis, and allergy shots. Your chronic urticaria patients, or patients that are having intermittent idiopathic urticaria, of course, asthma across all ages, anaphylaxis of any kind, angioedema or swelling, something that would be more rare but is out there in the community is hereditary angioedema, so just kind of keep an eye out for that. Atopic dermatitis, please send us those or go see a dermatologist, but we see atopic dermatitis every single day. Drug allergy or desensitization, eosinophilic diseases, food allergy is a really huge one. Mast cell disorders, I think that's like the sexy thing now, is to be diagnosed with a mast cell disorder. Everyone wants one, but very few people have one. Pruritus, of course, immune deficiency, so you know, there's really no one else, I don't think, that is equipped to be able to handle immune deficiency. Either primary or secondary immune deficiencies. Insect allergy, nasal polyps, again, these severe asthmatics, 40% or so may have nasal polyps as well. Look in the nose, get a rhinoscopy, or send them to somebody that can do rhinoscopy. A sinus CT is very helpful. Rhinosinusitis, vocal cord dysfunction, types of testing, so we skin test like I showed you, but then of course there's patch testing for contact dermatitis. Spirometry, I think it's very wise to always get a pre and a post bronchodilator spirometry. That's how you're going to catch that asthmatic versus someone that may have COPD, along with the history and risk factors and things like that. Nitric oxide measurement, which not a lot of offices will do, but I think it's very helpful. It can be a marker of airway inflammation. Certain cytokines are the driver for nitric oxide, and so it can help us make clinical decisions on what medication may be the best for the patient, as well as drug challenges, methacholine challenges if we're not sure if they have asthma, rhinoscopy, of course, immunotherapy, and biologics. I think we're all going to become very, very familiar with biologics over the next, like now, and over the last 5 years, and even more so over the next 10 or 5 years. And then that would be it. I think I'm going to do questions later, but thank you so much for your attention and time.
Dr. Daniel Snyder is a 2014 graduate of LMU-DCOM. He completed residency in anatomic and clinical pathology at the University of Tennessee Medical Center in Knoxville, where he served as chief resident. He completed cytopathology fellowship at the University of Kentucky. Dr. Snyder is board certified in anatomic pathology, clinical pathology, and cytopathology. In 2019, he opened Knoxville FNA Clinic, a freestanding outpatient pathologist performed fine needle aspiration biopsy clinic. Please help me welcome Dr. Snyder.
Thank you all, and thank you all for having me. I'm one of the few pathologists that actually sees patients on a daily basis, and probably one of the few pathologists that actually wants to see patients on a daily basis. But I opened a fine needle aspiration clinic to kind of fill a void we had in Knoxville for getting patients in quickly for needle biopsies. But the main focus of the topic is to help primary care providers understand when it may be appropriate to order a fine needle biopsy, when it could help your patients, what to do with some of the results that you may get, and things like that. So. As far as disclosures, I do own Knoxville FNA Clinic, but again, the focus of the topic, these biopsies, they can be ordered through interventional radiology. You could make a referral to surgeons. Some surgeons will perform FNAs themselves. It all depends kind of on regional variation on surgeon practice. The goals or the objectives at the end of this presentation, I want you to be able to describe the steps involved in the FNA procedure. I think that's very important to help patients understand what the procedure entails. That also helps you have discussion to kind of alleviate any fear the patient may have regarding a biopsy. I think the word biopsy itself is a very scary word for most patients. So to have a kind of full understanding, or at least a brief understanding of the procedure itself, I think that will help you have an informed conversation with your patients. I think it's also helpful to be able to educate the patients and the potential benefits of using an FNA to evaluate a mass. That also will help alleviate any fear. Recognize when the FNA may be appropriate for lymphadenopathy or other masses. Due to the time constraints, mostly what I am going to focus on is the head and neck region. That's also my primary area of practice. But really, FNA can be performed on any superficial area of the body. There are some places where other types of biopsies are more preferred. I think a large part of what primary care providers may experience are thyroid nodules or thyroid masses. So I do want to go over some indications on when FNA may be appropriate for thyroid masses and to help utilize the radiologic TIRAD scoring system to determine when to order an FNA versus continued ultrasound observation. And again, the overall goal would be to assist primary medical providers in determining when it may be appropriate to order an FNA. So. First, what is an FNA? A fine needle aspiration biopsy. It's actually a very minimally invasive procedure. It uses a very tiny needle, usually a 25 gauge. You can even use a 27 gauge or smaller needle, but oftentimes I use a 25 gauge needle. That needle is guided into a mass. Actually, anybody could perform an FNA. Any of you all could also learn to perform an FNA really with quite ease, but there are some limitations when it's not performed with pathology, at least assistance to help ensure that the sample is adequate. But the biopsy can be performed either with palpation or ultrasound guidance. If it's done with palpation, the mass is just localized between the fingertips and the needle is guided in. A few short excursions with the needle, the tissue is extracted and put on a slide and then sent to pathology or in my case, reviewed myself. It could also be done ultrasound guidance, which generally I prefer now, even though many of the masses that I do get in my office I can feel and target with a needle without using ultrasound. Using ultrasound guidance, it actually helps you target specific areas of the mass. On ultrasound, sometimes there's areas that look more suspicious than others, especially with thyroid nodules, which tend to be both solid and cystic. You can target the solid areas. So generally, even endocrinologists or interventional radiologists, they will now perform thyroid biopsies with ultrasound guidance, whereas probably 30 to 40 years ago, a lot of times they'd walk in the office, stick a needle in it, and hopefully they were hitting the mass. Sometimes it may have just been normal thyroid tissue. And then, let's see, I'll go on to the next one. So this is a basic setup of the clinic. This is my office. Generally, all that's needed is just an exam table and an ultrasound machine. If it's an office that's performing palpation-guided biopsies, you don't even need the ultrasound machine. So the steps involved, first you clean it with alcohol. The needle is inserted into the mass with kind of just a few short excursions. Usually a couple additional passes are performed into the mass just to make sure that adequate tissue is sampled. And then at that point, this is again the setup, just syringe and a couple needles. At that point, then the tissue is withdrawn, expressed onto a slide. Then the droplets, or the slides are smeared across a couple slides, and then those slides are stained for immediate evaluation to ensure adequacy. If it's performed in a hospital, generally interventional radiology can have pathology come down, and often that is preferred. Pathology will look at it and make sure that the interventional radiologist is getting out what they need. If it's performed in an endocrinology office, oftentimes they don't have that access to a pathologist, so then the tissue is sent to pathology. They're stained generally with a Romanovsky stain. The other name for it is called Diff Quick. It's just a real quick 3-stain process, takes a couple minutes to stain. In my practice, I'm able to step out of the room and look at the slides immediately to see what kind of tissue I'm getting out. That also helps triage the tissue for any appropriate testing if we do find metastatic cancer or other things. And then depending on what you see on the immediate evaluation, additional passes may be performed. So on average, I would say, at least in my practice, most of the time, 2 to 3 needle sticks into the mass for the patient, depending on what is obtained. Sometimes we'll go back and get a little bit more. If after 2 to 3 it's non-diagnostic or if you're not getting enough tissue, then the patient will still have more needle sticks at that point. But again, the needles are very tiny. It's a smaller needle that's what used to draw blood with. So patients tolerate it extremely well. We don't even use any local anesthesia with that. We do put a lidocaine cream on the patient, which I think probably is more of a placebo than anything. It probably helps some, but it's a very mild dose of lidocaine. And then we spray it with an ethyl chloride cooling anesthetic, which also helps numb the skin a little bit for the procedure. But again, for patients, it's extremely well tolerated just because the needle is very small. This is the Diff Quick stain, so it's just kind of a 3-dip stain process. So I'll step out of the room, I put the slides into the stains, and then I immediately look at them under the microscope. Then a bandage is placed over it. The bandage is just a tiny little dot Band-Aid. Patients sometimes will come in on their lunch breaks. They can go right back to work after the procedure. So it's really no restrictions as far as that. There's no complex treatment or follow-up treatments or anything like that as far as managing anything after the procedure, just since it is such a small needle. Oftentimes, depending on the facility, if a pathologist is available, even in the hospital, sometimes preliminary results can be discussed with the patient. Oftentimes in the hospital setting, that is not done. Usually it's whoever ordered the biopsy, those will be the one that, so in your case, it would be you that discusses the results. In my practice, I actually do discuss the preliminary results with the patient so that they can have kind of an understanding. I think a lot of times the scariest part of a cancer diagnosis is just waiting to get the cancer diagnosis. So the quicker a patient gets a cancer diagnosis, they can kind of approach it with optimism that now we know what it is, let's go get it treated. The advantages of an FNA, again, it's minimally invasive, minimal patient discomfort. The results are fast. This helps triage patients. If you're ordering this biopsy as a primary care provider, this can help triage patients for what type of doctor they need to go to next. In my case, if they're head and neck masses, thyroid nodules, things like that, if it is something that needs a surgery, this oftentimes, as a primary care provider ordering the biopsy, will help patients get triaged into surgery much faster, rather than just referring them directly for surgery and letting surgery determine if a biopsy is needed and things like that. If you refer them directly to a surgeon, oftentimes you're waiting weeks to get into the surgeon, then the surgeon is going around or turning around and ordering the biopsy anyway. So this can actually help bump them up a little bit in the list, especially in the cases of masses that are suspicious for malignancy. The surgeon can work them in oftentimes much quicker since they already have a diagnosis in hand before the patient hits their office. It's a cost-effective procedure. The average cost for the procedure for thyroid biopsy is $400 to $500. It's variable depending on where it's performed. In the hospital, it's a little bit more expensive just because of the hospital facility fees and things like that. It's very well covered by insurances. It's kind of the standard of care for thyroid nodule biopsies at this point, so really any insurance will cover it. And again, when ordering as a primary care provider, it's much quicker as far as getting the triage to the next doctor. There are some limitations to FNA. It is not preferred for breast masses. Core biopsy is preferred now just because oftentimes now with breast masses we're wanting to get as much information about the hormone status of the lesion as possible with the ER, PR, and HER2 status. That also helps the surgeons plan further management as well. That can be done on an FNA, but in a very limited capacity, so oftentimes now a core biopsy is preferred for that. There are some centers which will still use FNA for breast masses. A lot of times those are remote areas, kind of rural Appalachian areas. Questionable still in my mind whether it is still better to do an FNA or a core biopsy for those patients. The concern would be that the patient goes and gets an FNA in one of these rural settings, and then it does not get them the definitive diagnosis, or it comes back benign, which you can have false negatives with an FNA biopsy. And that may be the only time you get that patient in your office. So oftentimes for those, it is still better to order a core biopsy. It's also not preferred for lymph nodes when the concern for lymphoma is greater than the concern for metastatic malignancy. So this would be especially children or patients younger than 30. Those patients very rarely get metastatic cancers. That's not to say I've not seen a few of them, but oftentimes in patients that are younger than 30, your main concern for large persistent lymphadenopathy is for lymphoma. An FNA can help triage still. An FNA plus flow cytometry, which can be ordered, can help determine how concerned we are for lymphoma. The follow-up would still be either a core biopsy or excisional biopsy after that. So oftentimes for younger patients that have large persistent lymphadenopathy, I would encourage a core biopsy since they can do all of the definitive testing and actually lymphoma subtyping and get things moving a little bit faster as far as getting them to the treatment process. But again, FNA can still help triage those if it's uncertain, if the patient does have any type of a cancer history, especially if it's an older patient. Oftentimes 50 to 60-year-old patients, you're not sure if it's lymphoma or metastatic cancer. And I think an FNA being the quick, minimally invasive, I think it's still a great place to start. If we obtain metastatic cancer with an FNA, then core biopsy won't be needed at that point. It's a surgery referral or an oncology referral. The quality of the result is also highly dependent on the skill level of the person doing the biopsy. This can be mitigated as long as pathology is on site for the most part. So in hospital settings, a lot of times, if pathology is available, pathologists love to come down for these biopsies. So interventional radiology will call the pathologist down to do an immediate evaluation like I'm able to do in my clinic. It's also generally limited to masses 1 centimeter in size or greater than 1 centimeter in size, and that's especially true if you try to order a biopsy through interventional radiology. It's pretty rare that an interventional radiologist will attempt a biopsy of a 5 millimeter nodule. we do on a limited basis if there is a strong clinical concern, but for the most part, just the ability to hit a nodule of a much smaller size, especially depending on the depth of the lesion, is limited to lesions 1 centimeter or larger. And then sometimes still surgery is needed for a definitive diagnosis. Sometimes an FNA result may just come back that there are atypical cells present. That may result in either the need for additional biopsies or surgery just to get a definitive diagnosis. So when to consider an FNA, this should be considered anytime there's a palpable neck mass, especially if it's firm or fixed, and especially if it's persistent. I would start probably with an ultrasound or a CT scan to determine if it's a lymph node versus other. In my clinic, if it is a large palpable mass and it's very obviously suspicious to the primary care provider, oftentimes we skip that process since I do my biopsies ultrasound guided. Most hospital interventional radiology settings, they will oftentimes require some sort of imaging, so even just a basic ultrasound can help get the patients moved on to the biopsy stage. For lymph nodes, I would consider an FNA anytime they're persistent, especially if it's unexplained or worsening lymphadenopathy, and if there's not a known infectious or reactive cause, and if there's a high clinical or radiologic concern for malignancy. So basically, if it's a tiny little lymph node and the patient's just getting over a COVID infection, probably not a good reason to order an FNA at this point, but if the patient has cleared their COVID infection months ago and this lymph node is enlarged and it just keeps getting larger and larger, and especially when it starts to get firm or fixed, or if you've ordered an ultrasound, the radiologist pointed out something suspicious, that would probably be a good time to consider an FNA. For salivary gland masses, which we very commonly see from the primary care setting, a lot of times these are middle-aged smokers that present with masses kind of on their cheeks. They kind of sometimes will look like chipmunk cheeks because they can't form bilaterally or occur bilaterally. Those are very amenable to FNA procedure. Oftentimes that can help the ENT surgeon determine is this something that they need to go ahead and consider a surgery for or something they can't continue to observe. I still oftentimes recommend an ultrasound for those, especially if it's not palpably a firm, discrete mass or a very well discrete mass within the gland. An ultrasound can help exclude just the possibility of salladenosis or salladenitis, which would just be enlargement of the gland itself. An FNA can help with that. You can see inflammatory cells under that, but it's really not the best next step. I think an ultrasound would be much more useful for that to help determine whether there is a true mass there or not. And then thyroid nodules, and we're going to talk about some specific indications for thyroid nodules shortly. So there are many things that can occur in lymph nodes. We've seen metastases from all over the body. We've seen prostate in the neck. We've seen bladder cancer in the neck, any skin cancer, lots of melanoma, lots of squamous cell carcinomas. But I really want to mention one of the most common ones that we're seeing nowadays, and that's the HPV-associated squamous cell carcinomas of the neck. This has actually now surpassed, I think as of 2023, cervical cancer as the most common HPV-related cancer in the U.S. It more commonly presents as a neck mass, even though the primary tumor often originates in the tonsil. Most of the time, it hides occultly within the tonsil until it metastasizes. Then it presents clinically as a large, usually firm, palpable neck mass, oftentimes in the superior. Radiology will call it the level 2 region, but it's the very high levels of the neck, just under the mandible. It's got a better prognosis than the tobacco-related oral cancers. The 5-year survival rate is 68%. Some of that data is actually probably changing. There are some even more new treatments that are coming out for monitoring and treating HPV-associated squamous cell carcinomas. So, because I'm a pathologist, I do want to show some pathology pictures. This is what an HPV squamous cell carcinoma typically looks like to us under a microscope. Even without staining, based on the location and based on the morphology and based on the location of the lymph node in the neck, oftentimes I can suspect that this is an HPV-related squam just by the architecture of the cells. Oftentimes the HPV-associated squamous cell carcinomas, they're very monotonous, very dark, or the pathology term is hyperchromatic, and fairly uniform. But again, this was a sample from a lymph node, so we know these cells do not belong in the lymph node. And then we use immunostains to help support whether it could be HPV-related, and the term that you will commonly see now is a P16 squamous cell carcinoma. P16 is not a stain for HPV, but it's a marker that we use as a surrogate marker to determine which of these squamous cell carcinomas are more likely to be HPV-related, and the great majority of them will stain positive with P16. And actually, I usually present that to a patient as a good news finding. Most of the time, by the time they get to my office, they're fairly convinced that they do have cancer. But to tell them that this type of a cancer is the type that's often associated with HPV or caused by HPV is a far better prognosis than the type that is associated with tobacco smoking. The other common findings we see in lymph nodes is lymphoma. I wanted to show a good comparison of what lymphoma looks like under a microscope versus a reactive lymph node. Lymphoma oftentimes, does this thing have a, there we go. Does this have a laser pointer? Oh, perfect. So lymphoma, oftentimes what you will see are these larger cells, and they look fairly monotonous, and you will still see some smaller cells in the background. The smaller cells are the normal background lymphocytes. And the larger one, this is actually a case of diffuse large B-cell lymphoma that I had last week in a patient. Diffuse large B-cell lymphoma will very commonly present with large, bizarre, abnormal appearing cells, and really pretty characteristic under a microscope. It's pretty obvious when you see it. We still send these for flow cytometry. Flow cytometry is a test that actually will use some laser beams and different things to determine which markers are supposed to be on lymphocytes and which ones aren't. So we send a sample for that, and that helps confirm the suspicion for lymphoma. In comparison to a reactive lymph node, this was about a 23-year-old that just had enlarged lymph node that had been persistent, but probably some post-viral related lymphadenopathy. But in comparison, it's kind of a striking difference. Reactive lymph nodes, most of the time it's a mixture of mostly small cells with some kind of medium to large cells within. Oftentimes, if there is a strong clinical suspicion for lymphoma, we will still send them off for the flow cytometry to help exclude lymphoma. As long as it comes back benign, that supports what we're seeing under the microscope. So after you've ordered an FNA for a lymph node, once you get the result back, and as a primary care provider, that's kind of the decision to make if you're going to order biopsies yourself. What do I do with these results? If the result does come back conclusively metastatic malignancy, I would recommend referral to a surgeon, either ENT or a general surgeon, especially depending on the location of the body where the lymph nodes are. If the findings are suspicious for lymphoma, at that point you can refer them to hematology oncology for further workup. If it was obtained on a diagnosis from an FNA, generally they will proceed on either with a core biopsy or they may send them to a surgeon for an excisional biopsy. That helps determine the specific subtype of lymphoma and helps guide treatment. Or as a primary care provider, you could also, if you've ordered an FNA through interventional radiology, you could turn around and order a core biopsy through interventional radiology, and that actually is something that should be pretty well, you should be able to order that. If you're able to order an FNA, you should be able to order the core biopsy. The core biopsy will help give even more evidence that it is lymphoma, also help with the subtyping, and then at that point, when they get the referral to the oncology, that's also going to help things move a little faster. If the lymph node is benign, I do still recommend clinical follow-up. If you're still clinically suspicious, further testing could still be ordered. You could still order a core biopsy if you're still suspicious, or consider referring them to ENT for additional workup. But otherwise, generally, we like to follow these till resolution and at least ensure that there is no progression. Moving on to salivary gland, the most common tumor that occurs in salivary gland, it's a tumor called a pleomorphic adenoma. Microscopically, it's actually a very pretty tumor. We have this stuff that pathologists would call it troll's hair, and it's actually pink stromal material. Some of it's actually cartilage that these tumors make. It also consists of these benign ductal cells in the background, and then not as many here. These are actually called myeloepithelial cells. So it's kind of a 3-cell type tumor that we see in the salivary gland. We see these in all ages. We've seen them in kids as young as 8, 10 years old. We see them in adults up into their, I think 95 was the oldest one that we've seen. The reason these are important, they oftentimes will present as a pretty firm, hard mass, usually in the cheeks. You can get them in the submandibular gland as well. But they can transform to malignancy, and they give it a rule of 10s. About 10% will transform to malignancy over the course of 10 years. Often it transforms to either to a squamous cell carcinoma or some other high-grade salivary duct carcinoma or salivary gland carcinoma. So generally, even if this diagnosis comes back benign, regardless of the size, I would recommend an ENT referral. Depending on location, some ENTs will still watch these if they're very close to the facial nerve. But oftentimes, regardless of size, ENT will go ahead and consider surgery for these. The other common finding, which pleomorphic adenoma, they reported to be the most common in this region. Actually, I see Warthin tumors far more common. I don't know if that's due to the referral base or actually most likely due to just the smoking prevalence in our area. But Warthin tumors, it is a benign tumor. They do not have to be removed, but oftentimes patients want them removed. Oftentimes they can swell up with cyst fluid and become quite large and disfiguring on patients' faces. So that can fluctuate. If it swells up and goes back down, patients may not have any desire to have them removed. I do often still recommend ENT referral for these, unless it's a patient that say, well, I've had this thing for 40 years, it's not causing me any problems, then I think it's okay that you can still continue to watch them as a primary care provider. But these tumors, they're actually composed, let's go back. They're actually composed of a type of cell that are called oncocytes, which are pink cells. Oftentimes they form what's called a bilayer arrangement, and they surround actually lymphocytes. So there's a theory that these actually at one point started out as a lymph node. Due to the changes that smoking actually induces in the salivary gland, the lymph node has somehow taken up some of the oncocytic salivary gland cells, and then over time it has become a tumor. So it has been debated for many years whether it's true neoplasm or not. I think it is still classified as a true neoplasm, but it's more than likely actually a lymph node that has taken up some abnormal salivary gland cells and then over time morphed into this Warthin tumor. The full name for that is actually a papillary cystadenoma lymphomatosum, so we call them Warthin tumors. Dr. Warthin, I guess, decided he wanted to name this after himself. But it is a very common tumor that we see. ENT surgeons, again, will often take them out. It's also the common tumor that occurs bilaterally, so if a patient has palpable masses on both parotid glands, more often than not, it's going to be a Warthin tumor, and I can usually predict that even before we stick the needle in the patient, especially when the whole room smells like tobacco smoke. So that's kind of a good clue as a primary care provider of is this something you should be highly concerned about or not. I would still recommend at minimum an ultrasound and probably still referral for a biopsy. The other common thing you'll see in salivary gland is just a sialocyl or a simple cyst. Oftentimes these are still subjected to biopsy because they do present as kind of suddenly enlarged mass. Sometimes these are due to a sialolith or a stone within the gland, but cytologically they're actually classified non-diagnostic. It's really just this grungy cyst fluid that's obtained from them. Oftentimes the procedure itself can be therapeutic. The mass will shrink and sometimes disappear for sometimes days, sometimes months, sometimes many, many years. It may never recur, but oftentimes the cyst lining, since it is still within there, there is a tendency for these to recur, especially if there's a stone within the duct that's causing the obstruction that's causing the fluid to accumulate in the first place. So oftentimes when they do recur, we do still recommend either repeat FNA or referral to an ENT surgeon at that point to consider whether this needs surgery or not. At minimum, I would recommend continued ultrasound observation. Some of the tumors that can occur in salivary gland can be primarily cystic. So depending on where the biopsy is done, it is important to ensure that the part of the tumor that would have been, or part of the lesion that would be most suspicious was aspirated, which in a cystic salivary gland mass would be the solid component. If there is a solid component that's left behind after the cyst is aspirated, generally a repeat FNA would be needed. So that's why the category it will fall into is the non-diagnostic category, because there is still a small chance of a neoplasm or a malignancy in these tumors, or in these lesions. So I would still recommend at least close clinical follow-up, and if it does recur after aspiration, send them back either for another FNA or go ahead and make a referral to ENT. Other benign findings you can find in salivary gland, you can just get a reactive intraparotid lymph node. Malignant findings, there's a lot of them. We see these less common, but the most common one is actinic cell carcinoma. You can also get adenoid cystic carcinoma, salivary duct carcinoma, which is a highly aggressive, that's usually seen in elderly patients, highly aggressive type of cancer. We see metastatic cancer in parotid glands. A lot of times these are patients that have a history of either facial squamous cell carcinomas or melanomas. Sometimes these are actually not even metastatic to the gland. Sometimes it's actually direct spread in a patient that's had Mohs surgery in a lesion overlying the salivary gland. Oftentimes that will present several months or even years after a primary skin cancer has been removed as a sudden firm mass appearing in the gland. And then you can get lymphoma within the gland as well. So management after an FNA, if the diagnosis is conclusively neoplastic or malignant, I would recommend ENT referral just so they can manage whether this is a type of lesion that does need surgery, which oftentimes they do. If it is cystic and non-diagnostic, again, you could consider a follow-up ultrasound in 3 to 6 months to see if the cyst is still present, or clinically you can feel of it to see if it's still present. Or you can go ahead and refer to ENT, especially if these become large and painful, just because ENT will still oftentimes remove these. If it is not cystic, if it is a solid mass, and the result comes back non-diagnostic. So if you read the ultrasound report and they say a 3-centimeter solid mass in the left parotid gland, and you get a pathology report that comes back and says non-diagnostic, that means that probably not enough tissue was obtained during the procedure itself. At that point, I would recommend either referral for a repeat FNA or go ahead and send them to an ENT, which oftentimes they will go ahead and order a repeat FNA. If it's a reactive intraparotid lymph node, just like any other lymph node, I would recommend continued clinical observation. If the lymph node persists, or especially if it seems to be enlarging, do some additional testing. And then moving on to thyroid nodules, since those will probably be the most often thing you encounter as a primary care provider other than just lymphadenopathy. These could be discovered on palpation. More often than not now, they're actually discovered incidentally with CT imaging. We see patients that have car accidents or patients that have MRIs due to neck pain and things like that, and oftentimes it will find a thyroid nodule. The primary care providers, you'll get the report back and say thyroid nodule identified on a CT, and then you're wondering what to do with it. I would recommend an ultrasound at that point. An ultrasound is really the standard of care to determine which nodules need to be biopsied. Not every nodule in a thyroid needs to be biopsied, and 80 to 90% of them are benign. But the ultrasound will help triage which nodules need to be biopsied. Oftentimes patients will have multiple nodules, and it would be impractical to biopsy every nodule in the thyroid, so the ultrasound is very helpful in pinpointing which nodules would be most suspicious. I would also recommend the usual serologic testing anytime a new thyroid nodule is discovered in a patient, just because if they have an underlying thyroid disorder, that could be causing other symptoms or other issues with their health. There's two main guidelines that are used for thyroid ultrasounds. One of them is the older ones. It's the American Thyroid Association guidelines. These, for a primary care provider, they're often vague, and it's difficult to determine what to do with these. That they will a lot of times put them in a category, and some radiologists would give recommendations, but oftentimes it's pretty unclear what to do with them, and oftentimes these patients would get referred to endocrinology, and then endocrinology determines which ones to biopsy. In 2017, a bunch of radiologists, pathologists, and endocrinologists met and developed this TIRAD system, which is the most common one that you will see now on ultrasound reports. That's also regional. Some radiology groups may still use the ATA guidelines. Some don't use any guidelines. They just give recommendations, which I wonder sometimes are off the cuff. But the TIRAD system would be the ones that would be encouraged as far as determining which thyroids need a biopsy, and these are the guidelines. This table, you can pretty easily, if you'll just type in TIRADS on Google Images and print out a picture, I would recommend if you're someone that orders thyroid ultrasounds on a regular basis, have this printed out as a reference. That way when you get a report back, you can determine are these nodules that we need to continue to watch or we need to remove. It's a 5-tier system. Tiers 1 and 2 are either not suspicious or benign. Those nodules don't need biopsy. Oftentimes those are cysts or nodules that have clearly benign morphology on ultrasound. TIRADS 3 through 5, they've categorized them as mildly suspicious, moderately suspicious, or highly suspicious, which I hate those terminology because I think all three of those scare patients and providers alike. I wish they would say low indication, moderate indication, high indication for FNA, but nevertheless, they've named them mild, moderate, and highly suspicious. A highly suspicious TIRADS 5 nodule does have about a 20% risk of malignancy. All the categories tell us to do is to biopsy nodules that are even smaller, depending on how high the category is. TIRADS 3, they need a biopsy if the nodule's 2.5 centimeters or larger. TIRADS 5, 1 centimeter or larger. So that's where that scoring system comes from. But just because you see a TIRADS 5 or highly suspicious nodule on ultrasound, that is not a good reason to scare your patient, but it is a good reason to go ahead and order a biopsy. But that's a conversation I have with patients. They oftentimes come in terrified because they've obtained their ultrasound report and it says highly suspicious, and they're already convinced they have cancer. But again, 80% of those will be benign. If the TIRAD score recommendation is not included by radiology, there's some options. Oftentimes, the radiologist will still put a recommendation on their ultrasound report whether to observe the nodules after appropriate interval, or they'll go ahead and recommend a biopsy. The other option would be to ask your radiologist to start including the TIRAD score, and that'll be their preference or the group's preference, but that could be helpful. The other option would be if they do not include the TIRAD score, you could try to calculate the score yourself, and there's a very useful website, it's tiradscalculator.com. If all of the parameters are described on the ultrasound that were on this previous slide, so the echogenicity, composition, shape, margin, echogenic foci, which are calcifications, if all of those are described on the ultrasound report, you can pretty easily pop those findings into this calculator and it will assign a TIRAD score to it, and that can help you manage whether this is something you can observe with ultrasound or go ahead and consider an FNA. Some pictures for thyroid nodules. This is what a benign follicular nodule or a goiter would look like. The cells in these, oftentimes, they're pretty small and uniform. There's usually not much overlap. They're pretty evenly distributed. It doesn't project well in this, but oftentimes there's a background of a watery substance called colloid. This one, you can see the red blood cells, but the colloid doesn't show up. But a benign nodule, oftentimes it's composed of benign follicular cells and colloid, and that's a very reassuring finding when I see that under the microscope. Papillary thyroid carcinoma looks quite a bit different. The picture is blown up, so the cells are a little bit larger, but the cells really, they're usually not that much enlarged over the normal benign cells. But what we're looking for in these is actually most characteristically what's called an intranuclear inclusion. And it's actually an artifact that occurs when you smear the cells on the slide. But these cells are very fragile because they are malignant. And what actually forms are these intranuclear inclusions and then grooves, which would be these elongated things here, but the cells are actually folding on themselves and causing these abnormal findings. And those are the features that we see with a papillary thyroid carcinoma. The prognosis with a papillary thyroid carcinoma is still excellent. Most of the times these still stay pretty well confined to the thyroid, or at least the regional lymph nodes around the thyroid. But generally the surgery will be needed for treatment. If it's out into the lymph nodes, oftentimes that will be followed up with radioactive iodine therapy. This was a patient I actually had last week as well. This was a patient, she was about 40 years old. She'd had 5 years of asthma, but it was actually a stridor that was induced, and as you're sitting speaking with her, and it was a constant, very, very deep stridor the entire time that she's speaking. And she'd been to multiple providers. She was a morbidly obese patient, but she'd been told that this is just asthma. So I would recommend the key takeaway from this is feel your patient's necks. Instantly, when you feel her neck, you could feel a very large mass, or at least some asymmetry from the right lobe compared to the left lobe of her thyroid, and multiple lymph nodes in her neck. She had multiple cystic lymph node metastases from this papillary thyroid carcinoma. That has probably been going on for at least 5 years. She will still probably do very well as long as they don't demonstrate that it's spread any past the neck, but that is something, the key takeaway, definitely feel your patient's necks. Some other findings you may get back on a pathology report, some of the times they will fall into a category that say suspicious for a follicular neoplasm. The reason that category exists, there's two types of tumors that can occur in the thyroid. There's what's called a follicular carcinoma and a follicular adenoma. The only difference are the cells within a capsule, or have they penetrated past a capsule? If they're confined within the capsule, it's actually a benign tumor. If they've penetrated out of the capsule, it's a malignant tumor. So the only way that can be demonstrated is a surgery to actually remove the nodule. But now we actually try to avoid surgery since most of these do end up coming back benign. And we use molecular testing. So there's a test called Afirma, which is the most widely used. That's the one that I use, but also others, ThyroSeq and ThyroMir. That test can help put it into a category that tells us how suspicious the nodule is, whether it needs surgery or whether it just needs to be observed with ultrasound. If it does come back suspicious, then generally an ENT referral would be recommended at that point. I would not recommend an endocrinology referral for a thyroid nodule that needs a surgery. Endocrinologists do not do surgeries, so that would just delay care further. If you get a diagnosis that's positive for malignancy or suspicious for malignancy, definitely go ahead and consider an ENT referral. If molecular testing is not available, you could consider sending them to surgery to determine whether to do an FNA or a surgery. If the mass is large and clinically symptomatic, definitely consider a surgery referral at that point. Oftentimes ENT will do a request to repeat FNA with molecular testing. Other findings you will get, atypia of undetermined significance. That means there's some cells that are abnormal, not clearly benign, not clearly malignant. Oftentimes these are degenerative changes, but it still falls into a category that gives it a range of 10 to 30% risk of malignancy. Again, these were nodules that in the old days, some of them would be removed. If they're symptomatic, oftentimes they still are. If they're asymptomatic, then observation and repeat FNA after 3 to 6 months could be considered. But now with molecular testing, this also helps avoid any unnecessary repeat procedures or surgeries. So oftentimes when we get nodules in this category, we still send it out for molecular testing. Other findings, of course, medullary thyroid carcinoma and sometimes Hashimoto thyroiditis can present as nodules. Oftentimes the patient will have serology to support it, but occasionally a nodule will get discovered before the patient has ever had thyroid blood work. So sometimes under the microscope we get out a ton of inflammatory cells and other cell features that are suggestive of Hashimoto thyroiditis, and the biopsy can actually be a way to help diagnose that and support it with the serologic testing afterwards. So post-FNA management, if the nodule is benign and asymptomatic, I would recommend continued close ultrasound observation and thyroid serologic testing. If the nodule is benign and symptomatic, surgery referral, and if it's malignant, of course, surgery referral. Follow-up ultrasound observation, I would always recommend ordering follow-up imaging either at the interval recommended by TIRADS or at the interval recommended by the radiologist if a TIRADS score is not listed. If there's no recommendation, a general rule of thumb is to just repeat the imaging in a year. So if you've had a patient that's had a nodule identified on CT, you've ordered an ultrasound. If it's a small nodule and radiology is not recommending a biopsy at this time, at least do an ultrasound in a year to see if the nodule's growing. If it's changed in size, an FNA may be indicated at that point. And then I would still recommend a yearly ultrasound for at least 3 years for newly discovered nodules, if they're larger than a centimeter, just to ensure that they're stable and not actively growing nodules. Even if the biopsy has been performed, even if the biopsy comes back benign, a benign nodule still has about a 3% risk of cancer just due to sampling variation from the procedure itself. So I would recommend at least follow-up imaging for a few years after an FNA, even if the result comes back benign. So in conclusion, fine needle aspiration biopsies are a relatively simple, minimally invasive procedure. It's well tolerated by patients. A large amount of diagnostic information can be obtained through FNA. Ordering an FNA as a primary care provider can assist in triaging patients for appropriate follow-up. And familiarizing yourself with the TIRADS guidelines, even though we didn't have time to go through all of those guidelines, pull those up and definitely read through them. That way, when you see a TIRADS 5 or highly suspicious nodule on an ultrasound report, you understand kind of where the radiologist is coming from with that, and have an understanding on what to do with your patients. And that's it. Thank you all. Okay, that's fine. That's first. Yep.
For the sake of time, we're going to go ahead and move on with our next presenter. Dr. Leah Cobb-Snodgrass is a board-certified physician in child, adolescent, and adult psychiatry who serves as an associate professor and chair of behavioral health at LMU-DCOM. She is a graduate of the University of Kentucky College of Medicine and completed her internship, residency, and fellowship at Emory University in Atlanta. Dr. Snodgrass is a native of Middlesboro, Kentucky, and has been a member of the LMU-DCOM faculty since 2012. She is the course director for OMS2 Behavioral Medicine and Clinical Neuroscience courses and the rotation chair for the OMS3 Behavioral Health. She has given over 45 CME preceptor and faculty development presentations at the local, state, and national level. Please help me welcome Dr. Snodgrass.
Thank you, thank you. Before we get started, though, because y'all have been sitting here forever, let's everyone just stand up, okay? And let's stretch a little bit, like reach as high as you can to the ceiling, right? Yes, doesn't that feel good? Whew. And then take a deep breath in. All right, does that feel a little better? I hope so. Okay, so let's get started here. Let's see. So, maybe this one. Yes? No. There's, wait, he's bringing it up. It's going to be here, I promise. Okay. Is an advance. Well, hello. How are you? Good to see you. Good to see you as well. Is that good? Yep. Okay, gotcha. Perfect. This is so interesting. We don't have a fancy one like this at DCOM. All right, so adult ADHD, we're going to talk a little bit about self-diagnosis, performance enhancement, and also how it has changed with telemedical or telepsychiatry. So I don't have any conflicts of interest, which makes this very easy. The objectives are to review some of the epidemiology, the neuroanatomy, a little bit of neurobiology of adult ADHD. We will discuss the criteria, specifically how they are different in adults. And I want to differentiate between persistent ADHD, which is not controversial, and late or adult onset ADHD, which is pretty controversial. We'll talk about the process for assessment of ADHD in adults, look at some of the evidence-based algorithms for the treatment. We will talk a little bit about the pitfalls of the telemedical diagnosis of adult ADHD and some of the drivers for what we consider to be sometimes an over-diagnosis of ADHD and psychostimulant use, specifically in college age and young adults. So here is a case, and I encourage us to look at it because we'll think about it as we go through. So here's Madison. She's been struggling with schoolwork since starting college in the fall. She always has difficulty paying attention either in high school or middle school in certain subjects, but she still did well. She's been feeling more anxious lately because her study habits that worked throughout high school no longer seem to be effective. She feels completely inundated. The volume, the difficulty of her assignments is overwhelming. She finds herself constantly procrastinating, feeling guilty about her inabilities. And her problem sets have lots of careless errors, papers have numerous typos and errors, and sometimes, especially after doing poorly on an exam, guilt and anxiety about school becomes so high that she simply shuts down and avoids doing any work for the rest of the day. And she's seen a lot of ADHD content on TikTok recently and wonders if she may also have ADHD. Her college friend offered her Adderall, and while she hasn't taken it without a prescription yet, she wonders if she might benefit from it. So how many people know a little bit about adult ADHD? So about 5% of U.S. adults between the ages of 18 and 44 are diagnosed. 40 to 60% of kids with ADHD have persisting symptoms into adulthood. It may not be to the level of the full diagnosis, but there are persisting symptoms. We know that ADHD across the board, children, adolescents, and adults, highly comorbid, primarily with mood, anxiety, substance use, and even dementia. And comorbidities increase as one ages. So the question is, do the underlying symptoms decrease as one ages, or does the comorbidity take over and we treat the comorbidity and the ADHD goes under or unrecognized? We know that it's both nature and nurture. There's a 2 to 8 times increased risk of ADHD in first-degree relatives of the proband, so it's about 76% heritable. And we believe that's due to polymorphisms in 2 dopamine genes. One is a transporter and one is a receptor gene. So adult neurobiology, we know that there are smaller volumes of the frontal cortex, the cerebellum, and the basal ganglia. And we know that there are circuits. And so the frontal striatal pallidal thalamic circuit is a mouthful. So we'll just say circuits. And there is dysregulated feedback to the cortex through this circuit. We believe that those abnormalities remain throughout adulthood. The basal ganglia, which is responsible for some motor control, some executive function, behavioral inhibition, and even reward pathway, may normalize into adulthood. So what we often see is that inattentive symptoms persist into adulthood, but hyperactive impulsive symptoms start subsiding around puberty and continue to subside right on through into adulthood. And that would make sense based on this particular slide. And why do we even have ADHD? Well, there is hypoactivity of dopamine and norepinephrine in those frontal subcortical circuits, and norepinephrine and dopamine are responsible for behavior and cognition through the same circuits, and stimulants are given to block dopamine and norepinephrine reuptake and trigger its release so that we increase those free levels of dopamine and norepinephrine in the neurosynapse. And the more available that dopamine and norepinephrine is, the less likely we are to be inattentive, hyperactive, and impulsive. So the DSM-5 TR criteria for adult ADHD for everyone 17 and older, at least 5 symptoms are present of inattentive, right? Inattentive symptoms. For children, it has to be 6 or more. If all they have is 5 or more inattentive symptoms and less than 5 hyperactive impulsive symptoms, it would be attention deficit hyperactivity disorder, predominantly inattentive presentation, commonly known by lay people as ADD. Please keep in mind, clinicians, we don't have a diagnosis of attention deficit disorder. What we do have is ADHD, predominantly inattentive presentation. The other option would be at least 5 hyperactive impulsive symptoms. And if that's all they have and they have fewer than 5 inattentive, that would be your hyperactive impulsive presentation, or 5 or more of both, and that's a combined presentation. Several symptoms have to be present prior to age 12, therefore it usually requires collateral resources. There is significant recall bias. So you can ask your patient, so what was going on prior to age 12? Depending on their motivation, they may tell you that every symptom was present or hardly any symptoms were present. So if you can find a parent, a best friend, a coach, a teacher from when that person was under the age of 12, that would be great to confirm. It does have to be present in 2 or more settings. Usually in adults, it's home, academic, or occupational. And the wording has changed between DSM-4-TR and DSM-5-TR and says that clear evidence that symptoms interfere with or reduce the quality of function, no longer clinically significant impairment, which was the way it used to read. So this is much more subjective and up to interpretation. And it can't be due to another mental health condition, medical condition, or substance use. So the presentation in adults is a little different. So in childhood, a hyperactive child is one who can't sit still, who is constantly moving, running, climbing, jumping. They may have a tendency to seem driven by a motor. They're very loud. They're out of their seat all the time. But in adulthood, hyperactivity is driving at high speed. Hyperactivity is not being able to wait and being very impatient. So these are parents who are very snappy, and with that 76% heritability rate, they're very snappy with their child who also has ADHD. So it's really fascinating to have the whole family in the office. They can't relax, even when given the opportunity to do so, because they're so restless. They have that excessive energy, and they talk a lot and really fast. The inattention in children, what you're going to see is kids who avoid things that require sustained attention, who don't listen well, they're disorganized, they're forgetful, they make those careless mistakes in their homework and schoolwork, they are daydreaming, and they have an impaired sense of time. Adults do as well. But in adulthood, what you see is procrastination, putting it off until the very last second, then throwing something together to turn in. This could be academically or occupationally. Missing appointments or being very late to appointments, making careless mistakes in reports, disorganization and forgetfulness, and losing things all the time. Where are my glasses? Where's my phone? Where are my keys? I say that all the time, and I don't have ADHD, so I can't imagine how often I would say it if I did. And then we do see a higher risk of motor vehicle accidents and of traffic violations and citations in adulthood because they're not paying attention to where or how they're driving. Impulsivity in kids is blurting out answers before the question is completed, interrupting adult conversation, and having difficulty waiting their turn. In adults, it's having no filter. You think it, you say it, and there's nothing to filter it, okay? So this leads to a lot of relationship issues and a lot of issues at work and at school. They have a series of jobs. They like high-energy jobs. They get bored very quickly, so they move through those jobs every 1 to 2 months. So they have a laundry list of places that they have worked because they quit frequently. They start all kinds of projects without finishing them. This is also a criteria for hypomanic or manic episodes, so we start seeing some overlap here. Promiscuity can be an issue as well. Once again, pleasure-seeking in manic or hypomanic episodes can manifest with promiscuity. Temper outbursts, we do know that they have a very short fuse for the most part in adulthood, those with ADHD. And impulsive spending, which again is one of those risk-taking or pleasure-seeking behaviors that you see in bipolar illness. So we start to see that some of these become harder to tease apart from mood disorders, from PTSD, from generalized anxiety, etc. So some other impairments in adult ADHD that we see sometimes, but not always in kids, is emotion dysregulation. These people are very moody, very labile in their mood. Again, we see that with things like cluster B personality disorders, like borderline personality disorder. You can also, of course, see that with bipolar illness. Irritability, one of the pathognomonic criteria for manic or hypomanic episodes. Anger outbursts, those can also be seen in intermittent explosive disorder, in major depression. There's many different things that can manifest with anger outburst. A very low frustration tolerance. They try it once, it doesn't work, and they're done. They walk away. And just a lack of motivation. So they don't perform at the level that they should given their intellect and their resources. And we also see higher rates of criminality, of job loss, workplace impairment, very low job productivity, substance use disorders, and again, as we discussed, accidents and speeding tickets are more common. So persistence of childhood ADHD into adulthood, again, is not controversial. We know that about 40 to 60% of kids who have ADHD have persisting symptoms into adulthood, and usually it's primarily inattentive symptoms, but not for everyone. There can definitely be those hyperactive, impulsive, and combined presentations that persist into adulthood as well. The symptom persistence may not be to the level of the full disorder. So we did a multimodal treatment, we didn't do it, they did it, a multimodal treatment of ADHD study started in the early 90s. They recruited thousands of kids and controls, many of whom were diagnosed and treated for ADHD. Of course, the controls were not, and they followed them all these many years later. And what we saw is that about 15% of children with ADHD still met full criteria at age 25 and only 5% at age 38. So we see the lessening over time, and those are verified diagnoses of ADHD in childhood. Some predictors of persistence into adulthood is the initial number and severity of symptoms, the comorbidities, and most commonly it's social anxiety and oppositional defiant disorder. About 2/3 of kids with ADHD also have ODD. And any parental mental health problems was a predictor of persistence into adulthood. So late onset ADHD is controversial. So this would be symptoms emerging after age 17. Again, the MTA study followed this cohort of ADHD children and controls. And what they found is that 0.8%, less than 1% of the control group met criteria for ADHD with adult onset, meaning after they turned 17. 2.5% met criteria for adolescent onset between age 12 and 17. That's still considered to be a childhood onset. 95% of adults who initially screened as positive for adult onset ADHD based on symptom checklists, things that they were filling out of their own volition, met at least one exclusion criteria. Substance use or lack of two settings was the most common. So keep in mind that list of ways in which inattention, hyperactivity, and impulsivity present is not all that we have to look at. That's criteria A. We have B, C, D, and E as well, which includes you have to rule out some things, rule in some things, and make sure that two settings are present. The theory is if you do have late onset ADHD, perhaps you were able to compensate, either with intellect or with family structure and resources. It's called scaffolding. And I don't know why this comes in later, but it did. Most false positives based on symptom checklist had very complex psychiatric history, okay? And then compensation, the actual quote from this article is that late onset ADHD shares characteristics with child onset ADHD when parent rated, but differences for self-reports require investigation. Childhood resources may have delayed the onset of ADHD. So they are making a case for the fact that you can have ADHD initially for the first time diagnosed over the age of 17. But false positives are frequent in late onset ADHD, so we do have to be much more stringent and careful and strictly adhere to the DSM-5 TR criteria. The adult ADHD evaluation is very similar to that of the child. You're going to screen for medical conditions and psychiatric conditions that can mimic symptoms of ADHD. You're going to measure physical parameters such as heart rate, blood pressure, body height, or body weight and height. And you will use rating scales. They are subjective. You can use them initially and then with treatment to see if there is improvement. You're going to look at all those other conditions that could potentially look like ADHD, so mood disorders, anxiety disorders, substance use, etc. You will check those controlled substance prescription monitoring databases to make sure that they're not abusing, diverting, misusing their medication. And you may also want to get a urine drug screen to make sure they're taking it. Of course, mixed amphetamine salts would come up as amphetamine. Unfortunately, methylphenidate will not show in a standard urine drug screen, but you can actually order a few different things if you choose to look at that. And then using collateral sources to verify childhood ADHD diagnosis and to assess the level of impairment. So collateral is very important in the evaluation of adult ADHD. And sometimes it's just not available. I don't often find young adults or, early 20s, mid-20s, whatever. I very infrequently get to talk to their teacher prior to age 12, but I do my best. I at least reach out to their parent if they will sign the release. So conditions that mimic ADHD, hearing impairment, thyroid disorders, lead toxicity, liver disease, sleep apnea. For those of you who have ever known anyone with obstructive sleep apnea, you know that they are very cognitively impaired if they don't have CPAP, because it's only in that REM sleep that we actually clear toxins from the brain through the lymphatic system. So that's very important, and people with sleep apnea don't have good REM density. We also know that some drug interactions will mimic ADHD. Again, measure those physical parameters. Blood pressure and heart rate can be elevated by some of the medications. Weight will usually go down a little bit, not necessarily, but it can. It often does in children. It may be the same in adults as kids, I'm not sure. Height, we used to talk a lot about potentially losing height as the result of long-term administration of stimulants, but the MTA study found that that was actually not very true. And we're terrible at predicting adult height, so we don't talk about that as much anymore, but we do mention it. Rating scales, so there's a few here. The Adult ADHD Self-Report Scale, I put the links in so that you all can look at them. The ASRS is actually a good one. The only thing I don't like about it, when you click the link, it's free. You can print it out and use it in your practice, but what you'll see is that it has these boxes that are shaded in, and it kind of guides the eye to those boxes, so the person filling it out kind of recognizes, oh, I need to put a check mark in that box or I don't get credit. So if you can find one that's blank, that doesn't have the shaded gray areas, please do that. The CARS is the Connors Adult ADHD Rating Scale. It's the gold standard, but it costs a pretty penny. I use Connors scales with children and adolescents who I'm diagnosing for the first time. My practice pays for that, which is good, but I don't use them thereafter. I use the Vanderbilt scale, which is free online, and you can download the PDF. The Barkley Deficits in Executive Functioning Scale is very interesting. It's hundreds of questions, and it all focuses on executive functioning of adults. So please take a look at that. That you can see on UpToDate. For those of you who don't have UpToDate, please sign up to be a preceptor, and LMU-DCOM will give you access to all of our library resources, including UpToDate. I hope that someone's in here and heard me make that plug. The structured clinical interview, we have a few. So the diagnostic interview for ADHD in adults is free. Click that link, it'll take you to it. It's very nice, and we're gonna look at some examples of it here in a second. And then the ACE Plus version 0.2, all you have to do is put in your name and your email address, and you can download that one as well. So this is a DIVA example. So what you see is that what they're looking for is that you answer this question: do you often move your hands or feet in a restless manner, or do you fidget in your chair? Okay. And how was that during childhood? So it gives you some examples that you can prompt them with, either during adulthood, because again, hyperactivity in adulthood may be tapping with a pen, playing with something, fiddling with hair, biting nails, being able to control restlessness, but feeling very distressed as a result of it. So they give you some examples, and then they give you the examples during childhood. And if the person can tell you that under the age of 12, they had one or more of those symptoms, they can potentially meet the criteria. Again, this is very subjective, unless you have collateral, okay? And this goes on for every one of the criteria. So it looks long, but I also like the fact that it addresses later criteria. So here, it's asking us to make sure that it's present in two settings. And in adulthood, it's work or school, or in their family, okay? In childhood, it's primarily in school or at home, okay? It can certainly be in other places, but those are the two most common. So you would ask these questions, or in my opinion, don't feed them all of this. Just ask them and let them talk about it and see if they hit any of these criteria. Because if you just go down the laundry list, they're gonna be like, yep, that's me. That's all me, doc, yeah. Other conditions that mimic ADHD, again, psychiatric conditions, this is great if you have a mental health professional. However, a lot of stuff gets screened out before they ever even show up in your office in primary care. So mood disorders can be looked at using a PHQ-9. Anxiety disorders, you can always do a GAD-7. OCD can be looked at using a Yale-Brown obsessive-compulsive scale. Substance use disorders, do a Kraft or a Cage just to do the screen. Personality disorders, I would defer on that if I were you. And learning disorders and intellectual disability, they should come with some type of proof that that was the case when they were in school. Do not forget to check your controlled substance monitoring databases, which in the state of Tennessee is very creatively called the Controlled Substance Monitoring Database. And there's the link. And in Kentucky, they're much more creative. They call it CASPR. Also collect that urine drug screen if you feel that you need to. And keep in mind, methylphenidate doesn't show up, but you can get a chromatography or a mass spectrometry, and you can pull that ritalinic acid, which is what it would look for. So how do we treat it? We do the best we can with first line, and it's always medication, okay, plus or minus, but we do highly recommend cognitive behavioral therapy with a focus on executive functioning, because it has been found that if we focus intensely on one area of dysfunction, it will lead to the most meaningful and lasting changes. So CBTEF focuses on organization and or prioritization and or planning. So those are the things that they would actually go through a 12 to 14 week series of pretty intense cognitive behavioral therapy to figure out if that could help. Okay, so if they have no psychiatric or substance use comorbidities, and if everything else has been ruled out, and you know that this is an adult presenting with ADHD, stage 0 is most important because it is where you actually find out if they have the diagnosis. If you do not apply the criteria strictly, you cannot give the diagnosis. If you do not feel comfortable applying the criteria strictly, please refer them. If ADHD is for sure the diagnosis, refer for that CBTEF if it's available. If it's not, that's okay. And it might be that they have a mild to moderate case and they don't want to take medication, so just let them do the CBT, all right? Or they may say, you know what, I'm not driving 2 hours to get to someone who does CBTEF, so just give me the meds, doc. And if that's the case, stage 1 is exactly the same as for kids. Stimulants are first-line medication management treatment for ADHD in adults. If you try methylphenidate and it doesn't work at an appropriate dose for an appropriate duration, you will move on to mixed amphetamine derivatives or vice versa. Next would be atomoxetine, which is Strattera, or viloxazine, which is Qelbree. And if the person has tic disorder, anxiety, or if substance use is suspected, these would actually move to stage 1. You would not want to give stimulants to someone who has tics because it would worsen them, to someone who has anxiety because it will worsen it, or to someone who you suspect is using substances because they will abuse, misuse, divert. Maybe. Stage 4, we move on to bupropion or dizipramine, which is a tricyclic antidepressant. If they come to you with comorbid depression or nicotine dependence, if they're vaping. No one smokes tobacco anymore in my practice. It's very, very old-fashioned, but everyone carries a vaping pen. So if they're vaping and they're addicted, I may use the bupropion first line because it's the old Zyban. You all may remember it was used for smoking cessation for nicotine dependence. The tricyclics, as we're going to see in some of these algorithms, is way down on the list because they're lethal in overdose. I think the reason so many psychiatrists were so nervous many years ago is because that's all we had for depression and anxiety, and everyone was terrified that their very depressed patients were going to overdose and die. But now we have better ones, and we don't have to worry as much about that. And then stage 5, you would just use the agent not used in stage 4. And then in stage 6, the alpha-2 agonist, again, that's really more for kids than adults, but we do still use them in adults sometimes. So in an adult who's not pregnant and does not abuse substances, this is your algorithm. So they're not pregnant, they don't abuse substances, but they do have co-occurring depression, anxiety, or both, okay? So if depression only, you start with bupropion. If it's treated, that's great. If it's not, you're going to discontinue the bupropion and you're going to start a stimulant, right? And then add an SSRI or an SNRI. Now, the recommendation is to treat the depression first and then add the stimulant, okay? Get the depression under control because what's a primary issue with depression? Concentration, poor focus, right? So get that under control first, maybe do a little mini reassessment, make sure that's what you're dealing with, then add the stimulant. If that doesn't work, discontinue both of those and go on to dizipramine, the tricyclic antidepressant. If, however, it's anxiety only or it's anxiety and depression, you're going to treat with a combination of a stimulant and an SSRI or an SNRI. You can use Cymbalta, duloxetine, or you can use Effexor, which is venlafaxine. Are ADHD symptoms treated? Great, keep going. If it's just co-occurring anxiety, discontinue the stimulant and the SSRI, SNRI, whichever one you chose, and begin that atomoxetine. And then if it's treated, keep going. If it's not, go to the tricyclic. If it's not just co-occurring anxiety, if it's both anxiety and depression, move on to dizipramine, okay? And then if it's neither, we just looked at that. That's if there is no co-occurring comorbidities. That's the one that we just looked at on the previous slide. So if you have a non-pregnant adult with a current or a history of substance use, again, that moves atomoxetine or viloxazine. It's very close, newer first cousin into that first spot. And if it doesn't work, you can certainly taper it and try some bupropion if you choose to. And then if that doesn't work, taper the bupropion. If their prior substance use includes stimulant use, so cocaine, methamphetamines, crystal meth, or diversion or misuse of a prescribed stimulant medication, then you're going to start a tricyclic. If none of those criteria fit for this substance-using patient, you can go ahead and start a long-acting amphetamine or methylphenidate. You can start a stimulant at that point. These are some of the potential side effects of the psychostimulants. 1 and 2 are difficulty sleeping or insomnia and weight loss, anorexia. Those are your biggies, and the rest of them can occur and do sometimes occur. Heart rate and blood pressure can be elevated, obviously, by stimulants. And keep in mind, atomoxetine and viloxazine, while not prototypical stimulants, have stimulating effects. Black box warnings, methylphenidate, high potential for abuse and misuse, which can lead to substance use disorder, including addiction, can result in overdose and death. Mixed amphetamine salts have that one, and misuse of the drug may lead to serious cardiovascular events, including heart attack, stroke, death. That's a big one. Be sure that you talk to them about that. These are black box warnings. Bupropion, atomoxetine, viloxazine, dizipramine, all of those are considered to be antidepressant-like drugs. Atomoxetine, originally formulated as an antidepressant, performed poorly in the trials, was retrialed because it's an NRI, a norepinephrine reuptake inhibitor, performed well for the inattentive symptoms of ADHD and got that indication. Viloxazine came on the market with that indication. But they all have that increased risk of suicidal thoughts or behaviors for anyone under the age of 24, elevated to the level of a black box warning. For everyone, it's a potential side effect. And there's why. So a study of teens and young adults way back in the early 2000s found that 2% on placebo and 4% on antidepressants, specifically venlafaxine was the most offensive, had suicidal thoughts within the first 6 weeks of starting meds. And we think venlafaxine was probably the most offensive because of the activation it causes, that elevation in energy and movement and what have you. No one hurt themselves, no one killed themselves, but this was the report, and the FDA decided to black box it. I think we got the black box for this in 2006 or 7. So the take-home points for the treatment, ADHD goes unrecognized and undiagnosed in those over 18. We know that. Even with a verifiable history of ADHD as a child, many providers are very hesitant to prescribe stimulants because we fear that they will misuse or abuse the medication. But stimulants are first line, especially for adults who do not have substance use or psychiatric comorbidities. But you are going to get a thorough cardiac history, blood pressure and pulse, obtain an EKG if there's any positive symptom history or if there's a family history of issues, and consult cardiology prior to starting medication, either because there are some cardiac issues or if the patient just wants to. There is nothing wrong with getting a cardiology consult if the patient says, I'm afraid, I want the consult. By all means, we will sign you up. There's a link here. It's graphic 3 or table 1, and it will tell you all of the doses, all of the ways to start, all of the ways to taper. It's a very, very good table, so please take a look at that. All right, let's talk about telemedicine and adult ADHD. So the online ADHD diagnosis and treatment. So March of 2020, the DEA declared a public health emergency due to COVID-19 and waived the requirement for in-person evaluation prior to the prescribing of a controlled substance. So this would reduce time to connection with the provider, reduce distance traveled, right? Easier to schedule, better patient compliance, decreased stigma. I mean, these are all great things, right? So we were able to do telemedicine in a way that we had never been able to do it before because people could not come to our offices. However, what it led to is a proliferation of virtual platforms specifically for ADHD assessment and treatment, and there were market incentives driving less thorough and less scrupulous online ADHD medication providers. There was a lot of focus on productivity, so very short encounter times, shortcuts were being taken. Patient satisfaction was key because your reimbursement is linked to patient satisfaction in this country, which is stupid, but patients may expect or demand stimulants or else rate the provider monitor very poorly. And this was very financially lucrative because the more patients your provider could see, the more money you could make, and the more often they prescribed, the more follow-up you would get insured. So they were later exposed for many of these platforms, were exposed for substandard new patient evaluation time, 30 minutes or less, which is almost impossible, pressure to over-prescribe those stimulants to ensure follow-up. Patients were setting up multiple accounts and receiving multiple prescriptions from multiple providers. So it was actually compared to the opioid pill mills of the late 90s and early 2000s. And if you want to read a really cool expose, Fierce Healthcare right there has a really good one on all of the ones that got busted. So is it overdiagnosis? Is it self-diagnosis? Is it all of the above? Again, the criteria has loosened between DSM-4-TR and DSM-5, and these are the ways in which we see it, and we've already talked about it to a certain degree. And the little figure on the upper right is how elevated the Google search trend is for the term ADHD. It has doubled since 2004. So people are looking into it, researching it, figuring out what the criteria are before they ever come to your office. Okay, so they kind of know the drill. And there's increased recognition. Did everyone know that Bart Simpson had ADHD? Right? Did everyone know that the guy in How I Met Your Mother, who will always be Doogie Howser, MD, to me, did everyone know that he had ADHD, right? So this is a quote. As of May 2022, the hashtag ADHD has 11.4 billion views on TikTok. Many people credit these platforms with helping them realize that they had a diagnosis and then they seek treatment. However, misinformation is very prevalent. A recent study found that more than half of ADHD content on TikTok is misleading, and those are almost always provided by non-healthcare personnel. But the same study showed that if it's provided by a healthcare professional, that it's overwhelmingly more accurate and useful. So if they don't take TikTok away from this country, and if you choose to, jump on there and put some stuff that's actually true about ADHD. The other question about overdiagnosis is whether or not we are pathologizing underperformance. Is there a social genesis to ADHD? So we live in an overperforming culture. Elementary schools with higher expectations for academic performance and greater number of evaluations for that performance have much higher numbers of kids diagnosed with ADHD. It's just easier to say that Johnny can't keep up with Sally because Johnny has ADHD than it is to say that Johnny is just slower than Sally and doesn't have the intellect that Sally has and therefore is never going to be able to keep up with Sally. Okay, so that's much more palatable to parents and to the child themselves, obviously. So medicalizing underperformance into a diagnosis of ADHD is what we often see and hear about. And unfortunately, a diagnosis of ADHD leads to treatment of ADHD. So there has been a 6-fold increase in psychostimulants that are prescribed to adults between 1994 and 2009, and an 8-fold increase by non-psychiatric providers. This is a big deal, okay? This is a lot of medication floating around. And what happens when you have a lot of medication floating around? You can abuse it or you can sell it. About a third of undergraduate college students have taken stimulants without a prescription at least once. 82% find it easy or somewhat easy to get a hold of the stimulant. 5.4% of college students use stimulants in the past 1 year. I think that's way higher because these are the ones that are willing to admit it on the form. So this is way higher. Greater than half of undergrads with a prescription for stimulants are approached all the time and asked to sell it. Okay, so it can be lucrative if you have an official prescription. 63% of medical students using psychostimulants do so without a prescription. That's unfortunate and concerning. The main reasons given are they need to concentrate better, stay awake longer to study. All of this leads to performance enhancement. And this means a sizable number of young adults are obtaining prescriptions with the intent to distribute. Okay? That's just the bottom line. And I know we don't like to talk about this very much, but we have no choice. So the recommendation is to avoid the medicalization of underperformance. So keep in mind those secondary gains for young adults, especially those who are in undergraduate or graduate programs, and ask yourself 3 useful questions if this is the age range and the type of kid sitting in front of you. Is the inquiry related to ADHD consistent with an increase in external demands in the patient's life? They may have just started college like Madison did. They may have just started vet or dental or medical school. So is the inquiry consistent with an increase in external demands, right? It could just be adjusting to those external demands, right? It doesn't necessarily have to be ADHD. If yes, are these demands normal and reasonable? Maybe it's ADHD if that's the case. Or would anyone feel overwhelmed with the attention and impulse control levels required by these demands? The number of tasks, the complexity, having to sit for hours on end, study for hours on end, etc. If that's the case, and that is always the case almost in medical school and vet school and dental school, then it may not be ADHD. It may just be that they're overwhelmed with what they're being asked to do and they need to readjust. Does the patient have any reason to feel the need for an ADHD diagnosis and related medication? And think about performance enhancement, accommodations, more time on test, quiet test-taking environment, a note-taking scribe, reduced course load, right? These are all incentives to potentially get this diagnosis written down by a physician. And medication will help you focus. Medication will help you stay awake throughout the night for the entire weekend before the exam, and you will feel charged and ready to go, and you will fly through that exam on Monday morning at 8 a.m., which is when every test in medical school is given. So let's look at Madison. She's been struggling. Again, she just started college. These are her issues. So we ask ourselves those questions. So is the inquiry related to ADHD consistent with an increase in external demands in her life? Yes, it is. If yes, are these demands normal and reasonable? Do you all think these demands are normal and reasonable for Madison? She just started college. I think they are. And then the question is, does the patient have any reason to feel the need for ADHD diagnosis and related medication? Well, she's carrying around Adderall in her pocket. So she knows it's available. She knows she can do it. And you may have to talk to her about a few other things, such as what would happen if you were found with Adderall without a prescription on campus. So again, my recommendation, stick to the criteria strictly, okay? So they have to have several symptoms, that's more than one or two, present prior to age 12, and collateral sources are required to actually confirm that. Because again, they have recall bias and they're very subjective. If there are no collateral proof of symptoms prior to age 12, it's not ADHD. Okay? It has to be in 2 or more settings. If it's only present in school, if their only issue is my grades are not very good and I need them to be higher, that's not 2 settings, that's 1 setting. That's not ADHD. And it cannot be due to another mental health condition. Screen very carefully for those conditions that can include poor concentration as a diagnostic criterion: major depressive disorder, generalized anxiety disorder, bipolar disorder, post-traumatic stress disorder. You must discern true ADHD from those conditions that mimic ADHD. Okay, so that's my recommendation. Stick to the criteria. If you don't feel comfortable, refer them to me or someone else who does this for a living, and I promise we will get to the bottom of whether or not this is ADHD. These are my daughters who do not have ADHD, praise God, and who just graduated from high school. Some of you have seen them in other presentations. They're all grown up now and going away to college, so yay, go us. Any questions? Yes, sir.
They are on a stimulant, but they're like in their 30s and 40s. And I usually just make it clear to them, my goal is going to be to taper you off of this stimulant, because at this age, you know, in general, most people can find some kind of coping mechanisms to figure out these are the things that I need to do for organization. And a lot of times these patients are very resistant to that. But like I've had patients in residency that showed up as new patients with a CSMD that, you know, verified exactly what they had told me, and they're like in their 50s and 60s on Adderall, which is just ridiculous. And one of them ended up like getting admitted twice for SVT, and I was like, I'm not going to prescribe this to you anymore.
Yeah.
But it's very difficult when somebody, like they're just, and I understand that they're afraid of what's going to happen because they've been on this medication a lot of times for 15 or 20 or 25 years, and trying to convince them that it's okay to come off of that. And I have not had great luck doing that. A lot of times I talk to them about it and they just never come back. And I don't know like what your strategy is there, or if like how you go about that. And then like you were saying, whenever I do have adults come in and try to talk to me about, I think I have ADHD, a lot of times I do just want to refer them to psychiatry for a really thorough evaluation.
That's right.
Or, you know, I'll do like a PHQ-9 and a GAD-7, and it looks like they've got some pretty significant anxiety, and I try to talk to them about anxiety masquerading as ADHD, and a lot of times they're so convinced that they have ADHD that they really don't want to hear that.
Yeah.
And so, you know, I know I just threw like 3 questions at you,
That's okay.
but
I can keep up.
it's, you know, I'm not sure where you go with patients who, you know, have a pretty convincing PHQ-9 or GAD-7, but they're kind of anchored on ADHD. And then as far as patients that you're seeing in their 30s and 40s, who are just kind of like, at this point, they're regular people. They have a job, they have kids, you know, whatever. And they're just worried that, like you said, that their performance is going to decrease if they're not taking a stimulant.
Sure. So as far as the GAD and what have you, the major depression, if that's the case, if they're convinced that ADHD is a big part of it, I'll move them right on to Strattera, because it's indicated for that. If you have anxiety in addition to ADHD, why not help some of their inattentive symptoms? If they're that far into adulthood, it's probably primarily inattention. So look at Qelbree, which is viloxazine, or Strattera, which is atomoxetine. Throw them a bone. That's what they want, a medication. Make sure that they understand they have to take it every day, and it builds over time, takes 2 to 4 weeks to reach a therapeutic plateau, because if you don't, they'll think it's like a stimulant and they only need to take it on the days they need it, okay? The other question was more along the lines of how to get these people off of the medication. That is very unique and individual to that person, because that person could very well be so productive because they have had access to that stimulant for this long and it works for them. At this point, they're both psychologically and physiologically dependent on that medication. So you have to weigh the risk versus the benefit. If they're productive and doing everything that they need to do in life, and they have a solid, you know, home life, occupational life, academic life, whatever, they're not selling their drugs. If you suspect they are, you need to talk to them about that. They're not misusing them. They're not asking for prescriptions sooner than the 4 weeks. You just have to decide whether or not it's really necessary. As far as developing compensatory strategies, though, ideally, yes, adults do, you know, really teenagers do start developing compensations for all the things that are bothering them with their ADHD. The things that, though, they cannot compensate for often is the inattention. There's only a couple of ways that you can manage. If you can't stay focused and on task, it's really hard to force yourself into that by using an app on your phone, right? So the inattention hangs on for the most part. And again, you just have to dig into it. Make sure that the diagnosis is correct. If you suspect that a 30 or 40-year-old has been taking stimulants without an official legal diagnosis of ADHD for most of their life, then you need to reevaluate. You need to punt to psychiatry and let them do that very thorough investigation and make sure that we're not missing something here, or that we're not giving medications to someone who doesn't need them. The other group that I will mention, people who really like to keep a very thin, nice, fit body will sometimes seek out stimulants to stay thin. So they may have them prescribed in childhood or adolescence, and then they never get off of them because when they've tried to come off of them, they've gained 10 or 15 pounds. Okay, so that's another group that might push a little harder to keep those stimulants on board. Any other questions? All right, I know everyone's hungry and tired, so please feel free to enjoy the lovely luncheon that's been set up for you. If you have any questions, I'll be up front for a little bit. Thank you, guys.
There are a couple other things to take care of pretty quickly before lunch. If there are any questions for Dr. Kolinsky and Dr. Snyder, if you will relay those to me, I can get them to Amy, and they will be answered with answers posted on the conference website. And